Hi everyone, we are from Synapse Sprints. I am Dr. Manikam, a pediatrician. We as a team of almost 25 doctors are here to support you for your NEET PG preparation. Actually, our goal was to support students of 2026 and 2027 NEET PG batch. Since we were getting a lot of requisitions from the current batch, that is NEET PG 2025 batch, for their upcoming exams now within a week or so. So we thought we'll just help them with almost the most important high yielding topics. So here we are with a session for pediatrics. So I'm Dr. Manikam, as I've already introduced. I did my MD pediatrics from ICH, and I'm here to help you with your pediatrics exam. So I'll just be discussing the high yielding topics of pediatrics. So then we just thank our sponsor Brittle. This is just a doctor's gifting platform. You can just check it out in the internet. Okay. So just beginning with question number 1. So here we have so all these are almost high yielding questions, and they are from your previous year question papers. So we'll be discussing the questions as well as the options as well as further possible questions from the same topic. Okay, so the question number 1. Child presents to you with anemia, thrombocytopenia, bone pain. On examination, you see hepatosplenomegaly for this child. Light microscopy of bone marrow aspirate reveals the following image. What is the enzyme defect? So now from question you see you have anemia as well as thrombocytopenia. You have bicytopenia. So there is something occurring in the bone marrow. So you are just able to see that there is something happening with the bone marrow. Either it could be because of suppression of bone marrow due to infiltration or post-infectious suppression, or could be malignancy. That is what the infiltration could be due to any storage disorder or due to malignancy. You also see the child has got bone pain. So with these all histories, you see that there is some bone marrow involved. You also see the child has got some hepatosplenomegaly. So they have done a bone marrow aspirate and it reveals the following image. So this is the most common question asked repeatedly in all NEET PG examinations. So இங்க பாத்தீங்கன்னா இப்போ இந்த bone marrow picture பாத்தீங்கன்னா எப்படி இருக்கு ஒரு பேப்பர் ஒரு crumpled tissue appearance னு சொல்லுவோம். So you see there are a lot of leukocytes, the erythroid series, as well as you are able to see a crumpled tissue paper appearance here. So there is nothing but this crumpled tissue paper appearance is most pathognomonic sign of Gaucher's disease. So it's most commonly seen in Gaucher's disease, crumpled tissue paper appearance. So அப்ப அவங்க என்ன கேட்டிருக்காங்க, Gaucher's disease name கேட்கல, enzyme defect என்னன்னு கேட்டிருக்காங்க. Gaucher's ஒரு enzyme defect வந்து என்ன, as we all know it is glucocerebrosidase. So just a few points about Gaucher's. So Gaucher's அப்படின்னு பாத்தீங்கன்னா இதுல இருந்து ரிப்பீட்டடா கேட்கக்கூடிய high yielding facts. So Gaucher's வந்து ஒரு lysosomal storage disease. So it is a lysosomal storage disease due to glucocerebrosidase deficiency. We have almost 3 types here. One is non-neuronopathic. Neither endo neuronopathic, அதாவது neurological involvement இருக்கும். ஒரு சிலது acute and chronic னு அதை பிரிச்சிருவோம். So இந்த neuronopathic formsல death will be due to brainstem dysfunction. Here they will be having more of respiratory complications in all these non-neuronopathic forms. So when you take Gaucher's, glucocerebrosidase deficiency, lysosomal storage disorder, since glucocerebrosidase is deficient, the glucosyl ceramide or sphingolipidosis. So the glucosyl ceramide gets accumulated. Also you can see lipid laden macrophages, the Gaucher's cells. So Gaucher's, we have enzyme replacement therapy now. We can treat Gaucher's. So we can reverse the hematological complications of Gaucher's with enzyme replacement therapy. So these are all the major key points in Gaucher's disease. And the most important point is crumpled tissue paper appearance in bone marrow. So the answer here is glucocerebrosidase Gaucher's. If you see the next options, yeah, sphingomyelinase. Adha pathi theriyum. Sphingomyelinase endha disease la vara deficiency, Niemann-Pick disease. Hexosaminidase, Tay-Sachs disease. Hexosaminidase A, B nu vechirupom. Hexosaminidase A, Tay-Sachs la varum. Hexosaminidase B, we get in Sandoff's disease. Glucose 6-phosphatase, Von Gierke's disease. Actually make a chart, make a table, make a chart and paste it near your table. so that you can see it repeatedly. உங்களுக்கு அடிக்கடி ஞாபகம் வர மாதிரி வச்சுட்டே இருங்க. ரெப்பிட்டேட்டிவா இந்த enzymes and இந்த enzyme defects and corresponding disorders memorize பண்ணிட்டே இருந்தீங்கன்னா you will be able to easily acquire marks in exam. Okay, so next, 1 day old neonate has not passed urine since birth. What is the next step in management? So நிறைய நமக்கு காமனா எக்ஸாம்ல நீட் பிஜில பாத்தீங்கன்னா நார்மல் நியூ பார்ன் பத்தின கொஸ்டின்ஸ் ஜாஸ்தி வரும். நியூ பார்ன்ல போத் பெத்தாலஜி as well as நார்மல் வரும். பட் நார்மல் நியூ பார்ன் கொஸ்டின்ஸ் அடிக்கடி வரும். You should not miss marks in that normal newborn question because answering it is very easy. இப்போ இது பாத்தீங்கன்னா இப்ப நமக்கு இது ரெண்டு விஷயம் தெரிஞ்சிருக்கணும். ஸோ எந்த டைம் வரைக்கும் யூரின் போலனா இட் இஸ் நார்மல், எப்ப வரைக்கும் மெக்கோனியம் பாஸ் பண்ணலனா இட் இஸ் நார்மல். Listen carefully. If the child has not passed meconium for till 24 hours, it is okay. But after 24 hours, if it has not passed meconium, you have to evaluate. Urine பொறுத்த வரைக்கும் you can wait till 48 hours. So you can wait till 48 hours. Even after 48 hours, if the child has not passed urine, then you have to evaluate. அப்ப இங்க உங்க கேட்டிருக்கிறது 1 day old, just a 24-hour old neonate has not passed urine since birth. அப்ப what are you going to do? Are you going to continue breastfeeding? Are you going to admit the child to NICU? Are you going to give any artificial feeds? Are you going to start IV fluids? காமனா நம்ம பண்ற மிஸ்டேக் என்ன? டீஹைட்ரேஷன், 1 day old neonate யூரின் பாஸ் பண்ணல அப்படின்னு சொல்லி we normally say start IV fluids. இல்ல ஒரு சிலர் என்ன சொல்லுவோம், just put on artificial feeds ன்னு சொல்லுவோம். Exclusive breastfeeding till 6 months. That is what our infant and young child feeding practices advises us, IYCF. So never make mistake in that. So then when you see start IV fluids, no, you should not do that. You have to only do continue breastfeeding and just wait and watch. You have to continue breastfeeds, wait and watch. So this is one normal newborn question. Similarly, they have asked you, the child has not passed meconium in the first 24 hours. Is it normal? Yes, it is okay. Till you can wait till 24 hours. Even then, if the child has not passed meconium, you will start evaluation. Okay. So third question. So you see, this is also a common question where we tend to make mistakes. A 7-year-old boy presented with abdomen pain, oliguria, vomiting following chemotherapy. So you see there is some abdominal symptoms as well as the child has got some renal symptoms. Oliguria, likely to be acute kidney injury. Then you see the investigations revealed hyperuricemia, raised creatinine levels along with hyperkalemia. So what is the next best step in management? So when you read this, the first thing that comes to your mind, they have said following chemotherapy. So following chemotherapy initiation, all this has occurred. So now you all have come to a conclusion. என்ன நினைச்சிருப்பீங்க? tumor lysis syndromeன்றது உங்க எல்லாருக்கும் தோணிருக்கும். So tumor lysis syndrome, அப்போ இதுல மேனேஜ்மெண்ட் என்னன்றதுதான் question. So answer. So you have to answer for that. So hydration, second option is probenecid, third option allopurinol, fourth option rasburicase. So இங்க கேட்டிருக்கிறது next best step. So major treatment அந்த மாதிரிலாம் கேட்கல, next best step, அடுத்த ஸ்டெப் என்ன அதான் கேட்டிருக்காங்க. So இப்ப tumor lysis syndrome அப்படின்னா என்னன்றதை you should know, only then you can answer this question. So see, tumor lysis syndrome occurs in many tumors like ALL, AML, Burkitt's lymphoma, all those conditions. In leukemias and lymphomas, especially fast, rapidly growing tumors like Burkitt's lymphoma, you can see tumor lysis syndrome. Tumor lysis syndrome எப்ப வரும், ஏன் வரும்? டியூமர் செல்ஸ், நிறைய டியூமர் செல் பர்டன் அதிகமா இருக்கப்ப, அதனாலதான் Burkitt's lymphoma சொல்றோம். It is a rapidly growing tumor. Similarly, ALL நம்ம total leukocyte count 50,000 at the sometimes like 1 lakh மேல இருக்கப்ப, they are more prone for tumor lysis syndrome. So total count ரொம்ப increased இருக்கப்போ, அப்ப அந்த சமயத்துல பாத்தீங்கன்னா இந்த cytotoxic therapy, நம்ம chemotherapy, நம்ம கொடுக்குற chemotherapy cytotoxic therapy, when it acts on tumor cells, what will happen? Those cells will have nucleic acids, and the purine nucleic acids will just start breaking down. You will get hypoxanthine, xanthine, uric acid as an end product. So in the xanthine oxidase enzyme மூலமா நமக்கு வந்து you will be getting uric acid. Uric acid அதுக்கப்புறம் urate oxidase மூலமா will get converted to allantoin. So initial steps இந்த part எல்லாம் பாத்தீங்கன்னா hypoxanthine, xanthine. So இங்க xanthine oxidase இருக்கும். Then you see from xanthine you get increased uric acid. So xanthine வந்து uric acid வரும். So இதெல்லாம் xanthine oxidase ஓட part. Then from uric acid to allantoin, urate oxidase ஓட part. So all this will at the end result என்ன கிடைக்குது, நமக்கு uric acid கிடைக்குது இந்த இடத்துல. So you get hyperuricemia. அப்புறம் tumor cells வந்து phosphate release ஆகும். You get hyperphosphatemia. Also you get hyperkalemia. So என்ன சொல்லிருக்கோம், tumor cells வந்து potassium release ஆகும். So you get hyperkalemia. But நம்ம hyperphosphatemia வரும்னு சொன்னோம். tumor cells வந்து phosphate release ஆகும்னு சொன்னோம். அந்த phosphate will combine with calcium. So the calcium phosphate மாறி crystallize ஆகி can get deposited in the kidneys. Also that itself can cause renal injury. So இப்ப பாத்தீங்கன்னா but calcium levels will decrease. So they will have hypocalcemia. They will be having hypocalcemia, hyperuricemia, hyperkalemia, hyperphosphatemia, but they'll be having hypocalcemia. So then the Cairo Bishop's criteria. for tumor lysis syndrome. This is the main criteria for tumor lysis syndrome, the Cairo-Bishop's criteria. So you see here the Cairo-Bishop's criteria we have laboratory criteria as well as clinical criteria. Clinical more than 1% will take it significant. Laboratory will take it significant. So you see clinical criteria, the creatinine will be more than 1.5 times the upper limit of normal, or you may have cardiac arrhythmias, sudden death, or seizures. The creatinine 1.5 times the upper limit of normal, a part of acute kidney injury. Cardiac arrhythmias due to electrolyte abnormalities, especially hyperkalemia. So seizures could be due to hypocalcemia. So this moonla enna vandalum clinical criteria 1, அது 1க்கு மேல இருந்தாலே 1 or more than 1, it is significant. So creatinine more than 1.5 times upper limit of normal, cardiac arrhythmias, seizure. Laboratory criteria uric acid. Uric acid when it is more than 8 milligram per deciliter, hyperuricemia more than 8 milligrams per deciliter, or more than 25% increase from baseline. Potassium more than or equal to 6 milliequivalents from the 6 milliequivalents per liter, or 25% increase from baseline. Phosphorus when it is more than or equal to 4.5 milligrams per deciliter, or 25% increase from baseline. So when calcium, it is less than 7 milligram per deciliter, or 25% decrease from baseline. So இதெல்லாமே வந்து laboratory criteria. நம்ம பேசணும்ல hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia. So அப்ப அது எல்லாத்துக்குரிய cutoffs. When uric acid is more than 8, when phosphorus is more than 6 millimole per liter, when potassium is more than 6 millimole per liter, when phosphorus is more than 4.5 milligrams per deciliter, or when calcium is less than 7 milligrams per deciliter. So we take it significant. This is the Cairo-Bishop's criteria for tumor lysis syndrome. Even though we consider this tumor lysis syndrome. So tumor lysis syndrome poyachna, what we'll do? Actually, if chemotherapy start pannalum, say for leukemia, ALL in pediatric age group. So நம்ம என்ன செய்வோம் அப்படின்னு பாத்தீங்கன்னா, we'll just start the child on hyperhydration therapy. 3 liters per meter square per day. So எப்படி கொடுப்போம் 3 liters per meter square per day. Along with that, we'll be starting the child on allopurinol, as well as we'll be initially starting the child on dexamethasone, steroids. So where in case of ALL, in case of leukemias, so நம்ம steroids start பண்ணுவோம். அதுக்கு முன்னாடி hyperhydration therapyயும் allopurinol side by side start பண்ணிடுவோம். Allopurinol எதுக்காக கொடுப்போம்னா to decrease uric acid production. So the uric acid எங்க ப்ரொடியூஸ் ஆகுது? xanthine oxidase மூலமா தான் ப்ரொடியூஸ் ஆகுது uric acid, hypoxanthine, xanthine, uric acid. அந்த xanthine oxidase enzyme inhibit பண்றது தான் allopurinol. So we normally give allopurinol to prevent hyperuricemia. So to prevent tumor lysis syndrome நம்ம இவ்ளோ ஸ்டெப்ஸ் எடுப்போம். அங்கேயுமே first பாத்தீங்கன்னா preventionலயே we have hyperhydration therapy. So இப்போ அப்ப இந்த next best step in management here would be hydration. So hydration is the answer. So then the next option is probenecid. What is probenecid? You should also know that probenecid என்ன செய்வோம் அப்படின்னு கேட்டீங்கன்னா, probenecid வந்து uric acid ஓட reabsorption proximal tubules, renal proximal tubulesல கம்மி பண்ணும். எப்படி கம்மி பண்ணும்? Organic anion transporter inhibit பண்ணிரும். So uric acid will not get reabsorbed, it will be excreted in urine. So allopurinol, right now we have explained, xanthine oxidase inhibitor, rasburicase, a special drug. Hyperuricemia வர ஆரம்பிச்சிருச்சுனாலே we start them on rasburicase. Rasburicase can precipitate G6PD deficiency. Therefore, in any children with G6PD deficiency, you should not give rasburicase. So rasburicase ஓட work என்ன சொன்னோம்? uric acid ல இருந்து allantoin ஒரு ப்ராடக்ட் ப்ரொடியூஸ் ஆகுதுன்னு சொன்னோம். So uric acid ல இருந்து நமக்கு uric acid oxidase மூலமா urate oxidase மூலமா we get allantoin. So அந்த urate oxidase inhibit பண்றது தான் rasburicase. Recombinant urate oxidase தான் வந்து rasburicase. Sorry. So uric acid ல இருந்து we get allantoin. So அந்த allantoin from uric acid to allantoin we get it through urate oxidase. Recombinant urate oxidase is rasburicase. So we give rasburicase in the uric acid எல்லாம் allantoin convert ஆக ஆரம்பிச்சிடும். That is why we give rasburicase. We give whenever we see hyperuricemia more than 8 milligram per deciliter. Okay. So next, fourth question. It's a question from infectious disease. So it is more commonly asked question. So 12-year-old boy who presents with right upper quadrant pain for something involving liver, calf muscle pain, conjunctival suffusion, icterus, and fever with tender hepatomegaly. Most likely diagnosis. Actually, right upper quadrant pain can occur in many viral fevers, in dengue, hemorrhagic fever as well. So if you get options, first one is chikungunya, second one is leptospirosis, third one is dengue, fourth one is hepatitis A. You put options will match for leptospirosis as well as for dengue. But one thing here they have mentioned calf pain, calf muscle tenderness. So the most clinching clinical sign is when you squeeze the calf pain, when you squeeze the calf muscle, they'll just wince with pain. So when you squeeze the calf muscle, they'll just wince with pain. Those who are suffering from leptospirosis. So normally this significant finding will be seen in leptospirosis. So most likely diagnosis leptospirosis. Do we have any criteria for diagnosing leptospirosis? It is also a repeatedly asked question. The modified Fain's criteria. So this modified Fain's criteria is mainly for diagnosing leptospirosis. So leptospirosis, We have part A or clinical data, then part B, epidemiological factors, and part C is lab findings. So you see, so part A. So when you see part A, they have assigned scores for each of this part. The maximum score is for conjunctival suffusion, meningism, myalgia. So that carries the highest points in combo. If all these three are present, together, it carries 10 points. So normally you see there can be headache, fever, temperature more than 39 degrees Celsius, conjunctival suffusion, meningism, myalgia. When all three, conjunctival suffusion, meningism, myalgia, are present together, it carries higher points. There can also be jaundice, albuminuria as well. So jaundice is 1, albuminuria carries 2 points. So one thing I would like to say here is leptospirosis mainly involves renal system as well as liver. So leptospirosis, if treated at appropriate time, will prove fruitful. If not, the patient can go in for serious deleterious conditions. So next, part B here in score is epidemiological factor. In places where there is high rainfall, you have more chance of getting leptospirosis. Contact with contaminated environment, animal contact. What does the term animal contact mean? Rat. So especially the urine material of the rat, when it gets contaminated with our drinking waters, as well as through broken skin, through broken damaged skin, you can get this disease, leptospirosis. So bacteriological lab findings, see, like in other diseases, you cannot use culture for proving it. We have, yes, we have special cultures, but it is difficult. It is difficult to prove. So normally we go for serology. So serology carries highest points here. So ELISA, IgM, ELISA positive, SAT, then MAT. So MAT, what is MAT? Microscopic agglutination test. This microscopic agglutination test is commonly performed for leptospirosis. So when microscopic agglutination test is in higher titers, we take it positive. So the presumptive diagnosis of leptospira will be made when part A or part A and B together carries 26 points or more, or in total A, B, and C together carries 25 or more, we take it as leptospirosis. So that is presumptive. Possible leptospirosis when the score is between 20 and 25. Remember that modified Chains criteria is for leptospirosis. So leptospira, they are very well sensitive to penicillins. Okay. So next, an 8-day-old newborn was found to have TSH more than 100 international units per liter. So the next best investigation. So see that an 8-day-old newborn found to have TSH more than 100. So now our question is with congenital hypothyroidism. So when it comes to congenital hypothyroidism is a repeatedly asked question, as well as the most important topic in clinical practice, because hypothyroidism is most common preventable cause of mental retardation. So we have 4 options here. The initial option is urine iodine excretion. The second option is serum thyroid receptor antibody. Third option is radiotracer uptake with technetium. Fourth option is perchlorate secretion. If you're not confident with the answer, I can say that you can exclude one cause very easily here. One option can be excluded very easily here. We are talking about a newborn. So mostly we don't go in search of autoimmune conditions here. Second option is serum thyroid receptor antibody. So what you can do, you can exclude that option with a bit extra confidence, with a bit extra surety. And you see other 3 options. Other 3 options include urine iodine excretion, radiotracer uptake with technetium, perchlorate secretion. But anyway, you just cannot guess. You have to learn this. We'll just start with the congenital hypothyroidism management. Before that, I would like to tell congenital hypothyroidism, the TSH values like how we present in adults, 5 to 5.5 international units per liter, that is not applicable for newborns. So newborns less than 2 weeks and more than 2 weeks, the cutoff is different. For less than 2 weeks, if TSH is more than 20 international units per liter, we take it significant. We have to evaluate. For more than 2 weeks, if TSH is more than 10 international units per liter, we have to evaluate. I repeat again, for less than 2 weeks in newborn children, if TSH is more than 20 international units per liter, we will be evaluating the child. For more than 2 weeks, if TSH is more than 10 international units per liter, we will be evaluating the child. Okay, next. See, this is the major chart. So in this chart, I'm not going to explain the entire chart. You can use this chart. Also, we have in IAP, the Indian Academy of Pediatrics has published a guidelines and IAP standard treatment guidelines for congenital hypothyroidism. You can just avail them directly from the internet, and that is a very good source for learning congenital hypothyroidism. So our question here is congenital hypothyroidism. Congenital hypothyroidism, the cutoffs are very important. Less than 2 weeks. Significant is more than 20 international units per liter. More than 2 weeks, it is more than 10 international units per liter. This is TSH, the TSH cutoff. So remember that just with TSH, you cannot identify hypothyroidism. Say if you have a central hypothyroidism, that is a pituitary cause. What will be the finding? Actually, normally what we used to say, in case of primary hypothyroidism, and the problem is with the thyroid gland. In case of primary hypothyroidism, and the problem is with the thyroid gland. அப்ப என்ன ஆகும் நமக்கு? TSH வந்து ஃபீட்பேக் மெக்கானிசம் மூலமா இன்க்ரீஸ் ஆகும். ஏன்னா T3 T4 ரிலீஸ் இருக்காது, அது கம்மியா இருக்கும். அப்ப ஃபீட்பேக் மெக்கானிசம் மூலமா இது ரிலீஸ் ஆகாதனால நமக்கு TSH will start increasing. இது when there is a pathology with the thyroid gland. Whereas when there is a pathology with your pituitary, TSH release அந்த அளவுக்கு இருக்காது. So T3 T4 கம்மியா இருக்கும். நார்மலா T3 T4 கம்மியா இருந்துச்சுன்னா நம்ம என்ன எக்ஸ்பெக்ட் பண்ணுவோம்? TSH ரைஸ் ஆகும் காம்பன்சேட்டரியா. பட் இங்க அது நடக்காது. TSH will be normal. So இந்த மாதிரி பிக்சர் இருக்குன்னா you have to think of central hypothyroidism. அப்ப நமக்கு ஒரு क्वेश्चन கேட்கலாம், just TSH மட்டும் hypothyroidism ரூல் அவுட் பண்ண முடியுமா? நோ. வித் TSH எஸ், நம்ம அதை ஸ்கிரீனிங்கா யூஸ் பண்ணலாம். பட் வெறும் TSH வச்சு பாத்தீங்கன்னா TSH நார்மலா இருக்குன்னு சம்டைம்ஸ் நீங்க எக்ஸ்க்ளூட் பண்ணிட்டு போயிருவீங்க, பட் they could be having central hypothyroidism. So we have to see TSH, the free T3 and free T4 thyroid hormones. So entire thyroid profile பார்த்தா தான் we can just rule out. TSH ஓட கட் ஆஃப் டிஸ்கஸ் பண்ணிருக்கோம். So next we'll move moving here. இங்க சார்ட்ஸ் பாத்தீங்கன்னா இப்ப எனக்கு TSH 80 மேல, இப்ப நம்ம வந்து எதுல TSH ஸ்கிரீன் பண்றோம்? நியூபார்ன்ல congenital hypothyroidism ஸ்கிரீனிங் இப்ப மஸ்ட் எவ்ரிவேர் யூ ஷுட் டு ஸ்கிரீனிங். எய்தர் நம்ம ஹீல் பிரிக் பார்க்கலாம், இல்ல கார்ட் பிளட்ல பார்க்கலாம். சோ இப்ப நான் கார்ட் பிளட்ல பாக்குறேன், 80க்கு மேல இருக்கு TSH இனிஷியல் ஆனா ஸ்டார்ட் ட்ரீட்மெண்ட் இம்மீடியட்லி, டோன்ட் வெயிட். இதே எனக்கு இப்போ TSH வந்து 40க்கு மேல இருக்கு அப்படின்னா ஜஸ்ட் 72 hours கழிச்சு TSHம் ஃப்ரீ T3 T4 எடுத்துட்டு we are going to wait. என்ன பண்றோம்? கன்ஃபர்மேட்டரி சாம்பிள்ல 72 hours கழிச்சு கார்ட் பிளட்ல TSH 80க்கு மேல இருந்தா இம்மீடியட் ட்ரீட்மெண்ட், நம்ம வெயிட் பண்ண போறதுல ட்ரீட்மெண்ட் ஸ்டார்ட் பண்ணிட்டு we are going to evaluate. 40க்கு மேல இருக்கு அப்படின்னா we are just going to send confirmatory venous sample for TSH and free T3 T4 after 72 hours of age. இப்போ இங்க என்ன பார்க்க போறோம்? நம்ம நார்மலா பார்த்தது T4 நார்மலா இருக்கு, பட் TSH மட்டும் கொஞ்சம் ஹையரா இருக்கு. T4 இஸ் நார்மல், உங்களோட ரேஞ்ச்ல கரெக்டா இருக்கு, பட் TSH வந்து இட் இஸ் இன்க்ரீஸ்ட், ஹையரா இருக்கு. ஸோ லெஸ் தேன் 2 weeks க்கு 20 சொன்னோம், மோர் தேன் 2 weeks க்கு 10 கட் ஆஃப் சொன்னோம். இந்த பிக்சர்ல இருந்தா ஐம் கோயிங் டு ரிப்பீட் TSH ஆஃப்டர் 2 weeks. 2 weeks அப்புறம் பாக்குறப்ப நம்ம கட் ஆஃப் என்ன 10 சொன்னோம். அப்ப 10க்கு கம்மியா இருந்துச்சுன்னா இட்ஸ் நார்மல். 10க்கு மேல இருக்குன்னா 3 weeks கழிச்சும் இருக்கு, பட் வித் நார்மல் T3 T4 அப்படின்னா you're just going to start treatment, you're not going to wait. So என்ன சொல்லிருக்கோம்? 80க்கு மேல இருக்குன்னா immediate treatment, 40க்கு மேல இருக்குன்னா confirmatory sample send பண்ணிட்டு we are going to wait. So அப்படி sample 72 hours கழிச்சு send பண்றப்போ when TSH is high but there is a normal T4 அப்படின்னு சொன்னா அந்த TSH என்ன கட் ஆஃப் சொல்லிருந்தோம்? less than 2 weeks க்கு 20, more than 2 weeks க்கு 10. So அதுக்கு மேல இருக்கு TSH, T4 நார்மலா இருக்கு அப்படின்னா திருப்பி TSH 2 weeks கழிச்சு ரிப்பீட் பண்ண போறோம். அப்படி ரிப்பீட் பண்றப்ப if TSH is less than 10, wait, ஏன்னா கட் ஆஃப் பார்த்தா. ஆனா if it is more than 10, 3 weeks கழிச்சு திருப்பி பார்ப்போம். அதாவது after the age of 3 weeks, மொத்தமா 3 weeks, after the age of 3 weeks persistent-ஆ இதே மாதிரி இருக்குன்னா I'm just going to start treatment and reassess again at 3 years. Okay. So இப்போ if the child has got a low T4, whatever TSH may be, if the child has got a low T4, irrespective of TSH, you have to start treatment. T4 வந்து lower normal, lower limit of normalலையோ இல்ல even if the value is lower, அதான் என்ன சொல்றேன்னா நமக்கு ஒரு ரேஞ்ச் இருக்கும் for T4. அந்த lower limit of normal இருக்கு, lower range of normal குள்ள வந்தா கூட you have to evaluate. T4 கம்மி தான். So if T4 is low, irrespective of TSH value, we are going to start treatment. We are going to do imaging for finding out the etiology. If T4 and TSH are normal, then it is normal, no issue. இது 40க்கு மேல இருக்கிறதுக்கு. If TSH is 20 to 40, between 20 to 40, again திருப்பி ஒரு சாம்பிள் எடுக்க போறோம். So அந்த சாம்பிள் எடுக்கிறப்போ you are just going to repeat TSH. அப்ப என்ன அந்த ஏஜ் கிரைட்டீரியா படி. So if it is less than 2 weeks, 20க்கு மேல இருக்கா, more than 2 weeks, 10க்கு மேல இருக்கா அப்படின்றத பார்த்துட்டு திருப்பி we are going to evaluate. அதேதான். So chart, use this chart. Also you have IAP guidelines. One thing which I wish you all should remember is cut off of TSH. So cutoff of TSH when the less than 2 weeks it is 20, more than 2 weeks it is 10 for evaluation. எப்ப 80 க்கு மேல இருந்தாலும் start treatment immediately, never wait, because this is a preventable cause of mental retardation. 40 க்கு மேல இருக்குன்னா 72 hours கழிச்சு sample send பண்ண போறோம். T4 எப்ப லோயரா இருக்குனாலும் irrespective of TSH value treatment start பண்ண போறோம். பட் T4 நார்மலா இருக்கு, TSH மட்டும் ஹையா இருக்குன்னா 2 weeks கழிச்சு ரிப்பீட் பண்ண போறோம். அப்ப TSH கம்மி ஆயிடுச்சுன்னா no issue, we are just going to leave. But still if it is high, then we are going to start treatment. We'll again re-evaluate the child at 3 years of age. So if T4 and TSH are normal after 72 hours, then no issue, it is considered normal. So இதுதான் நமக்கு இந்த 3 ends of chart. The chart will be much more simplified in IAP standard treatment guidelines. You can also have a look at that. Okay. So இப்ப இந்த இடத்தை பொறுத்த வரைக்கும் எனக்கு எப்ப 80 100 இருக்குன்னா immediate treatment start பண்ண போறேன். Dose என்ன? Levothyroxine dose is 10 to 15 mics per kg per day in newborn. Don't forget that. In other pediatric age groups, we say 3 to 5 mics per kg, but in newborn it is 10 to 15 mics per kg per day. Never forget all this. Also, central hypothyroidism miss பண்ணிடுவோம், வெறும் TSH மட்டும் வச்சிருந்தோம்னா அதையுமே just remember. அப்புறம் clinical scenario கொடுக்கலாம் congenital hypothyroidism. Congenital hypothyroidismல there will be delayed passage of meconium. அதே மாதிரி நம்ம ossification centers, bonage எல்லாமே delay ஆகும். That can be wide open anterior fontanel. So you see a dull apathetic face. So அவங்களோட ஃபேஸ் போட்டிருப்பாங்க, ஒரு டல் apathetic face with a protruded tongue, ஒரு macroglassia picture மாதிரி கொடுத்திருப்பாங்க. So congenital hypothyroidism, preventable cause of mental retardation, very well treatable. ட்ரீட்மெண்டோட டோஸ் தான் இது. ஓகே, இப்போ நான் லீவோதைராக்சின் ஸ்டார்ட் பண்ணிட்டேன். அவங்க எப்படி ஃபாலோ அப் பண்ண போறேன் அப்படின்னு கேட்டா 2 weeksலயே வில் பி ரிப்பீட்டிங் T4, 4 weeksல வில் பி ரிப்பீட்டிங் TSH. அப்ப நம்ம ரேஞ்ச் இருக்கும், ஒரு ரேஞ்ச்குள்ள இருக்கும்ல, இந்த free T4 should come to the upper limit of that range, whereas TSH should come to lower limit of normal. இப்ப சே எனக்கு TSH முதல்ல 20 22 அப்படிலாம் இருந்துச்சு நியூபார்ன் பீரியட்ல அப்படின்னா ஆஃப்டர் 2 weeks கழிச்சு நான் பாக்குறப்ப என்னோட லோயர் லிமிட் ஆஃப் நார்மல் இப்ப சே 0.5 யூனிட்ஸ் வைக்கிறேன்னா ஐ ஹவ் டு ரீச் டில் தட் எண்ட். அதான் இப்ப அந்த நியூபார்ன் பீரியட்ல இனிஷியலா பாக்குறப்ப சே ஆஃப் 0.5 யூனிட்ஸ் வரைக்கும் ஐ ஹவ் டு ரீச், ஐ ஹவ் டு டில் ரீச் தி லோயர் லிமிட் ஆஃப் தி நார்மல். தட் இஸ் ஹவ் ஐ அம் கோயிங் டு டைட்ரேட். So for initial 6 months we'll be seeing monthly. After this we'll be seeing monthly. Then 3 months once. So இப்போ எனக்கு congenital hypothyroidism எந்தனால வேணாலும் இருக்கலாம். Thyroid dysgenesis, agenesis, or can be due to thyroid dysharmonogenesis. But dysgenesis or any structural abnormality na lifelong thyroxine replacement. But dysharmonogenesis ku what I'm going to do? I can stop my treatment at 3 years. திருப்பி TSH வச்சு evaluate பண்ணி பார்க்கணும். அப்ப if it is beginning to rise, then I have to put the child on lifelong treatment. So dysharmonogenesis doubt இருந்துச்சுன்னா you can stop the treatment, that too at 3 years of life, wait for a brief period, follow up with repeated TSH levels. So then thyroid gland பத்தி கேட்க thyroid gland questions நிறைய வரும். Then see thyroidல hypothyroidism plus deafness, Penrod syndrome. This would be a common question. So any congenital hypothyroidism கண்டுபிடிச்சா you should do hearing screening to find out this Penrod syndrome. Okay, Pendrin gene mutation. So the Penrod syndrome you can find out here. So all this we have to know very well about congenital hypothyroidism, because congenital hypothyroidism is a repeatedly asked question. Then imaging பொறுத்த வரைக்கும் we do ultrasound of gland as well as radioisotope study, technetium, scintigraphy, to see how the gland uptakes the iodine. So on the radioisotope iodine or some other radioisotope. So radioisotope study we used to do there. Okay, நமக்கு இதுல இருந்த question, what is the next best investigation? They have asked radioisotope study. So we'll be marking radioisotope study here. Okay, next. So far we have discussed in depth about congenital hypothyroidism. Next question, 10-month-old infant brought with complaints of jerking of limbs towards body. So on examination there is a developmental regression. EEG shows hips arrhythmia. So in the hips arrhythmia point வந்துருச்சுனாலே we know that we are discussing or we are dealing about West syndrome. So what is the drug of choice? அது West syndrome சொன்னோம்னா அந்த infantile spasms. So infantile spasm பத்தி தான் பேசுறோம். So EEG show hips arrhythmia, what is the drug of choice? So see, there's a jerking of limbs towards body, nothing but and the salam spells then they are meaning. So how will be the salam spells? Head, there will be a forward flexion. Similarly, there will be an inward movement of the arms towards the body. So a 10-month-old infant brought with complaint of jerking of limbs towards the body. So here you will be having West syndrome, hypsarrhythmia, developmental regression, and this infantile spasms. So EEG show hypsarrhythmia. So what is the drug of choice? We will be giving ACTH. ACTH steroid is the drug of choice. In case if you are not having ACTH, we will be going for high dose prednisone. So in the West syndrome has to be managed immediately if the child is developmentally normal. So West syndrome கண்டுபிடிக்கிறோம். If the child is developmentally normal, the regression போறதுக்குள்ள as soon as possible we can treat with ACTH. West syndrome can also be secondary to birth asphyxia, other structural brain abnormalities as well. But in the idiopathic irukna, we have to manage it very immediately. It is an emergency. So regression prevent when you are treating immediately with steroids. ACTH is the drug of choice. But in case if you don't have ACTH, you can go for high dose prednisolone. So for West syndrome, infantile spasms with West syndrome, we treat with ACTH. In other conditions, we can also use vigabatrin. So in non-West syndrome conditions. Okay. So next, a male child presented with arthralgia, abdomen pain. So on examination, you see palpable purpura over both the lower limbs. Very commonly asked question. So you see palpable purpura over both the lower limbs. So which of the following is the first line treatment for this condition? So there are 4 options: steroids, methotrexate, cyclosporin, azathioprine. Before that, you should know what this condition is. So the history is very well directing us towards Hinox-Conlin purpura. Hinox-Conlin purpura, what do we have? We have palpable purpura with arthralgia, diffuse abdomen pain, and then so you will be seeing in biopsy what you will be seeing. You will be seeing leukocytoplastic vasculitis. So for Hinox-Conlin purpura, also there will be IgA deposition in the mesangium. So in the renal system, there will be IgA deposition. Not only in renal, you can also see it in skin as well as in the intestine. So all this is about Hinox-Conlin purpura. So you have palpable purpura, a diffuse abdomen pain, arthralgia. You can also see IgA deposition in the mesangium, skin, as well as in the intestine. This is a vasculitis. So the most common vasculitis in pediatric age group is IgA vasculitis. Part of that is nothing but your Hinox-Conlin purpura. Hinox-Conlin purpura pathina maximum presentation eppadi irukuna, initially namakku it will not be presenting as palpable purpura. In the palpable purpura varradhukku munnadiye they will be having arthralgia, or sometimes they will be having severe abdomen pain. So they will be in search of surgical causes. So surgical team they will be roaming here and there. So surgeon side perspective in the case போயிட்டு இருக்கும், abdomen pain நிறைய evaluate பண்ணிட்டு இருக்கும். So later after 15 or 20 days, we'll be able to see palpable purpura. Then we'll be thinking in terms of this vasculitis, IgA vasculitis. So also you see this can even mimic intussusception. So Hinox-Conlin purpura can even mimic intussusception. So what is the main line of management here? In all cases, we are not going to use steroids. If there is renal involvement, severe renal involvement, or severe gastrointestinal involvement, if there is a renal involvement or severe gastrointestinal involvement, we treat with steroids. Just for palpable purpura, if he has got only palpable purpura with arthralgia, we don't immediately start them on steroids. If there is severe GI involvement or if they have renal involvement, we go for steroids. Okay, so the most common IgA vasculitis here is the most common vasculitis in children is IgA vasculitis, Hinox-Conlin purpura. Next, a 6-year-old male child presented with edema and anasarca. Diagnosis of minimal change disease is made. Which of the following is true? Nephrotic syndrome deal பண்றோம்ன்றது தெளிவா தெரிஞ்சிருச்சு. So இந்த ஆப்ஷன்ஸ் பாத்தீங்கன்னா light microscopy shows effacement of podocytes னு கொடுத்திருக்காங்க. Light microscopy shows effacement of podocytes. First option. Second option பாருங்க good response to steroids. Third option பாருங்க more common in adults. Fourth option பாருங்க non-selective proteinuria. If actually பார்த்தோம்னா if we are in a hurry, we'll just tick this option. We'll tick effacement of podocytes. That's correct. But see, they are given light microscopy. So in the way they can confuse us. Light microscopy கிடையாது. எதில இருக்கும் effacement of podocytes? We get it in electron microscopy. So electron microscopy only shows effacement of podocytes. So podocytes are nothing but a part of that glomerulus Bowman's layer epithelial layer oda or extension foot process தான் வந்து podocytes. So light microscopy electron microscopy shows effacement of podocytes. Ruled out. Good response to steroids. Yes, the minimal chain disease in solderona, right? We are having a very good response to steroids. More common in adults. ill. Minimal chain disease more common in pediatric age group. That is why the nephrotic syndrome of pediatric age group, nephrotic syndrome that is occurring in pediatric age group, especially between 2 to 6 years, is highly treatable because it shows good response to steroids. Okay, so more common in adults are? No, wrong. It is common in children. Non-selective proteinuria? No, it is selective proteinuria. So excessive albumin release urine. So this is a selective proteinuria. So the correct option here is good response to steroids. We have to know a lot of facts as well. See? Nephrotic syndrome being age group 2 to 6 years more common. So most common pathologic lesion or pathology correlating with nephrotic syndrome in pediatric age group is pediatric one, that is minimal change disease. Yeah, it got term of minimal chain disease. Light microscopy will not have many findings. Not much findings. Biopsy. Electron microscopy we get effacement of podocytes. Minimal change they show very good response to steroids. Nephrotic we have nephrotic range proteinuria. Hypoalbuminemia less than 3 grams. Less than 3 milligrams per deciliter hypoalbuminemia. So then you have edema as well as hyperlipidemia. These are the major features. You will have very good response to steroids. There will be effacement of food process. Light microscopy, there will be not much findings. Minimal chain disease are more common pathologic lesion in pediatric age group. Whereas in adults, more common is FSGS, focal segmental glomerulosclerosis. So focal segmental glomerulosclerosis. So next, when it comes to other one that is commonly what we see is membranous nephropathy. Adult this is more commonly associated with malignancies. It's more commonly associated with malignancies like lymphomas. Okay. All this will not show much good response to steroids, but this will show good response to steroids. Which one? Minimal chain disease. எனக்கு இதே question இங்க ஒரு 11-year-old female presented with edema and anasarkan சொன்னா age group மாறிடுச்சு. Minimal chain disease ஓட incidence will be very minimal. அந்த children you can think of 11-year, அதுவும் female, ஒரு sudden onset, we'll be thinking of lupus nephritis. So age group matters. Next, which of the following cannot cause seizure? So almost we know. So electrolyte abnormalities cause a seizure. Hypoglycemia can cause seizures. In electrolyte abnormalities, hyponatremia, hypocalcemia, and hypomagnesemia can cause seizures. But hypokalemia can never cause seizures. Hypo and hyperkalemia can never cause seizures. Hypoglycemia can cause, hypocalcemia can cause, but hyponatremia can also cause, but hypokalemia can never cause seizures. So this is also repeatedly asked question. Next, a 10-year-old child presents with diarrhea and weight loss. You see, they have a clinching feature here. The child's height and weight is less than the expected. So the child has some sort of failure to thrive. Also, it has got diarrhea and weight loss. It has got a persistent diarrhea. You see, the lab analysis has showed HLA-DQ2 positivity. They have given it directly, a direct question. So they have not asked you some evaluation, this and that. They have showed, lab analysis has showed HLA-DQ2 positivity. And the other thing, which of the following will you advise for this child? But still this question is a bit incomplete. So we can add 1 to 2 more points to this question. Say the child has got elevated IgA tissue transglutaminase level. If I say this point, you all will know that this is celiac disease. So now come to the options. You see, fat-free diet, lactose-free diet, low carbohydrate diet, gluten-free diet. This you all know. For celiac disease, we have to give a gluten-free diet. Okay. So celiac disease அப்படின்னு சொல்றப்போ it is mainly due to gluten sensitivity, the gliadin component of gluten. So they'll be having gut mucosal injury, hypersensitivity because of this hypersensitivity to gliadin protein of gluten. So they'll be presenting with diarrhea. Sometimes they'll not be presenting with diarrhea. They'll be just presenting with short stature with anemia. Especially in Western countries, they're telling that any child who's being evaluated for short stature with anemia should also have celiac disease in the corner of your mind. You should also think about celiac disease. So celiac disease or first investigation enna seiven? Yes, gluten based diet nala varudha. And the gluten start பண்ணதுக்கு especially weaning period la weaning diet start பண்ணனா வரும். So gluten nala varudhu appdi solranga. I'll be just checking IgA tissue transglutaminase levels. I would like to suggest a clinical point here. Sometimes for some children there will be a selected isolated IgA deficiency. So in that conditions நீங்க வெறும் IgA TTG பாத்தீங்கன்னா it will be decreased. So அது decreased இருக்கனால celiac disease childக்கு இல்லன்னு கிடையாது. சைல்டுக்கு ஒரு IgA டெஃபிஷியன்சி இருக்கு, அதனால என்டையராவே IgA மாலிகூல்ஸ் உடம்புல இம்யூனோகுளோபுலின் A மாலிகூல்ஸ் லோயரா இருக்கும், IgA TTGயும் கம்மியா இருக்கும். ஸோ எப்ப IgA TTG பாக்குறீங்கனாலும் added up check IgA as well. Immunoglobulin A தனியா சேர்த்து பாத்துருங்க. So if immunoglobulin A is normal, IgA TTG is normal or decreased, then there is nothing to worry about celiac disease. If IgA is normal, the IgA TTG level is very much elevated, we think of celiac disease. Celiac disease or a treatment, main a gluten-free diet. We have to restrict gluten. Automatically, the gut will start healing itself. Okay. Next question. A very repeatedly asked question in all exams, in NEET exam, any set exams, for any quiz. Everywhere this question is being asked. So a 3 days old female baby presented with severe hypotensive shock and was in altered sensorium. You see the lab evaluation showed hypoglycemia, sodium level of 119 milliequivalent per liter, potassium levels of 6.8 milliequivalents per liter. Potassium levels of 6.8 milliequivalents per liter. Despite fluid correction and inotrope, the shock wasn't corrected. The genitals of the child is as below. What they have showed, it is an ambiguous genitalia. See, actually this looks like Vitus clitoris, but there is a clitoromegaly as well. Malformed scrotum, there is no testis. So actually it looks both like a male and a female. So when you see, if you get a confusion like this, we call it as a ambiguous genitalia. For a female, if you see, the labia and anything is not well defined. So you can just take this as a virilization of a female external genitalia. Okay. Also you see, the child has presented with altered sensorium, hypoglycemia, hyponatremia, hyperkalemia with acidosis. Blood gas showing acidosis. Also, despite fluid correction and inotrope, the shock is refractory. So in the hyperkalemic metabolic acidosis with the hypoglycemia, something to do with mineralocorticoids. So hypoglycemia because of cortisol deficiency, this hyperkalemia, metabolic acidosis, shock, everything, both cortisol as well as mineralocorticoid deficiency. This is something dealing with adrenals. So what are we dealing with? Ambiguous genitalia, where congenital adrenal hyperplasia. Okay. So what will be the next immediate line of management? They are asking next immediate line of management. Do ultrasound to look for internal genitalia. Do TSH levels. Do karyotyping. Start on stress dose steroids after collecting samples for cortisol and 17-hydroxyprogesterone. இதுல ஒவ்வொரு லைனுமே ரொம்ப முக்கியம், கேர்ஃபுல்லா பாருங்க. அல்ட்ராசவுண்ட் இன்டர்னல் ஜெனட்டாலியா, எஸ் கரெக்ட், நான் வந்து எக்ஸ்டர்னல் ஜெனட்டாலியா எப்படி இருக்குன்னு பார்க்கணும். இன்டர்னல் ஜெனட்டாலியால நான் மேல்னு வச்சிருக்கேன்னா முலேரியன் ஸ்ட்ரக்சர்ஸ் இன்டர்னல் ஜெனட்டாலியா இருக்கான்னு பார்க்கணும். ஃபீமேல்னு வச்சிருக்கேன்னா உள்ள இன்டர்னல் ஜெனட்டாலியா ஓவரிஸ் இருக்கா, இல்ல வெதர் இட் இஸ் ஓவோ டெஸ்டிஸ், வாட் அபவுட் த முலேரியன் டக் ஸ்ட்ரக்சர்ஸ், ஃபீமேல் யூட்ரஸ் எல்லாம் வெல் ஃபார்ம்டா இருக்கா, இல்ல இட் இஸ் மால் ஃபார்ம்டா, எல்லாமே செக் பண்ணணும். ஆம்பிகுவஸ் ஜெனட்டாலியான்றப்போ எக்ஸ்டர்னல் ஜெனட்டாலியா பாக்குறப்போ இன்டர்னல் ஜெனட்டாலியா என்னென்ன ப்ராப்ளம்ஸ் இருக்குன்றத ஹேவ் டு ஃபைண்ட் அவுட். ஓகே. So next question, TSH levels. இது எல்லாமே ரூல் அவுட் பண்ணிடுங்க. ambiguous genitalia ஸ்கிரீன் பண்ணணும். immediately we are not going to do that. Karyotyping, karyotyping இந்த இடத்துல யூஸ்ஃபுல்லா இருக்குமா? நான் இப்ப karyotyping ஏதாவது ஒரு லார்ஜர் karyotyping ரோல் என்ன, ஒரு லார்ஜர் குரோமோசோமல் டெலிஷன்ஸ், லார்ஜ் குரோமோசோமல் பெத்தாலஜி அபரேஷன்ஸ் பார்க்கறேன்னா karyotyping will be useful. இப்போ எனக்கு my part congenital adrenal hyperplasia யோசிக்கிறப்ப it will not be that much useful. Next option is start on stress dose steroids after collecting samples for cortisol and 17-hydroxyprogesterone. இதுதான் எனக்கு கரெக்ட் ஆன்சர். திஸ் இஸ் தி கரெக்ட் ஆன்சர். ஏன் எனக்கு பாப்பா எதுல இருக்காங்க, ரிஃப்ராக்டரி ஷாக்ல இருக்காங்க, ஐனோட்ரோப் ரிஃப்ராக்டரி ஷாக். இப்போ என்னோட நெக்ஸ்ட் ஸ்டெப் ஆஃப் மேனேஜ்மெண்ட் ஷுட் பி டு கரெக்ட் தட் ஷாக். அப்ப நான் ஷாக்கை கரெக்ட் பண்ணணும்னா இங்க என்ன ப்ராப்ளம், ஸ்டீராய்டு இல்ல, ஸ்ட்ரெஸ் ஹார்மோன்ஸ் இல்ல, அதனாலதான் பாடி இஸ் நாட் ரெஸ்பாண்டிங் டு தட் ஸ்ட்ரெஸ் அண்ட் டஸ் வாண்ட் டு ஷாக். அப்ப ஐ ஹேவ் டு கிவ் ஸ்ட்ரெஸ் டோஸ் ஆஃப் ஸ்டீராய்ட்ஸ் 100 mg per meter square per day வச்சு இனிஷியல் ஸ்ட்ரெஸ் டோஸ் ஸ்டீராய்ட்ஸ் சிவியர் ஷாக்ல இருக்கப்ப கொடுக்கணும். So hydrocortisone you have to replace immediately. And if it is a newborn child, we'll also put him on fludrocortisone, mineralocorticoids. At the same time, we'll also collect samples for cortisol and 17-hydroxyprogesterone. Since a female child ambiguous genitalia, adu shock la present aayirukanga, more likely to be 21-alpha hydroxylase deficiency. Appo அந்த டைம்ல 17-hydroxyprogesterone will be elevated. So pathway பாத்தீங்க அப்படினா, you have to see that here. So everything here begins from cholesterol. Initially from cholesterol, you'll be having pregnenolone. So that is through 3-beta hydroxysteroid dehydrogenase, it gets converted to progesterone. Through 21-alpha hydroxylase, it gets converted to deoxycorticosterone, corticosterone, and aldosterone. So deoxycorticosterone and 11-beta hydroxylase மூலமா corticosterone. So if my 21-alpha hydroxylase is affected, what will happen? Automatically aldosterone production irukadu. So my mineralocorticoid production will be defective. So mineralocorticoid production will be defective. அப்ப என்ன ஆரம்பிக்கும்? இந்த pathway இந்த சைட்லயே இருக்காது. So my pathway will not be in this aldosterone aspect. Where it will move? It will start moving to the other side. So it will move to pregnenolone. அப்படி என்ன ஆரம்பிக்கும்? இது இந்த pathwayல இல்லாதனால it will go towards sex steroid production. DHEA, androstenedione, testosterone. So dehydroepiandrosterone, androstenedione, testosterone பக்கம் போயிடும். So obviously all this adrenal androgen excess as well as this increased testosterone in female will cause virilization. So 21-alpha hydroxylase males will not manifest that much. Yes, they may also present with shock, but male பொறுத்த வரைக்கும் later stages present பண்றாங்கன்னா they will be presenting with precocious puberty. But whereas for a female, you can notice this in the immediate newborn period as ambiguous genitalia. Yeah, because எனக்கு 21-alpha hydroxylase தான் மெயினா என்னோட aldosterone production pathwayல இருக்கு. So என்னோட aldosterone production pathwayல I'm having 21-alpha hydroxylase. இது டிஃபெக்டிவ் அப்படின்னா இங்க எனக்கு அல்டோஸ்டிரோன் வராது. ஸோ அல்டோஸ்டிரோன் வரலைன்னா ஆட்டோமேட்டிக்கா மை பாத்வே மூவ்ஸ். எங்க போக ஆரம்பிச்சிருது? பாத்வே சேஞ்சஸ் டு செக்ஸ் ஸ்டெராய்ட்ஸ். ஸோ இட் மூவ்ஸ் டு 17-hydroxypregnenolone, dehydroepiandrosterone, androstenedione, testosterone. ஸோ அந்த சைட்ல போக ஆரம்பிக்கிறப்ப my immediate complaint would be nothing but virilization in female, peripheral precocious puberty in male. Okay, so next, இப்போ இதுல இன்னும் நிறைய enzyme deficiencies இருக்கு, நிறைய common questions-உம் they can ask from here. So common questions, அதுக்கு அடுத்து வேற என்னெல்லாம் கேட்க முடியும் இதுல இருந்து கேட்டா 3-beta hydroxysteroid dehydrogenase என்னென்ன findings வரும்? See, எங்க இருக்கு 3-beta hydroxysteroid dehydrogenase? From pregnenolone to progesterone we have 3-beta hydroxysteroid dehydrogenase. இப்போ 3-beta hydroxysteroid dehydrogenase defectiveனா இந்த entire pathway-உமே இருக்காது. I'll not be having cortisol, I'll not be having aldosterone, also I'll not be having the sex steroids as well. So entire pathway gets collapsed in 3-beta hydroxysteroid dehydrogenase. So they will also present with shock. They are also more prone for shock. Shock presentation with 21-alpha hydroxylase தவிர I can also get it in 3-beta hydroxysteroid dehydrogenase. Similarly, இப்போ எனக்கு அடுத்த enzyme நம்ம காமனா கேக்குற question 11-beta hydroxylase. So 11-beta hydroxylaseல என்ன வரும்? This corticosterone cortisol form ஆகாது. But still then எனக்கு deoxycorticosterone DOCA will be available. Deoxycorticosterone will be available. This deoxycorticosterone and deoxycortisol can also perform the functions of mineralocorticoids. கிட்டத்தட்ட aldosterone மாதிரி they can also perform the function. So what will happen? This deoxycorticosterone increase in itself will lead to salt retention. Aldosterone function play பண்ணிடும். So salt retention வரனால 11-beta hydroxylase children will present with hypertension. So they can ask you some options, they'll be giving you certain enzymes and they'll be asking which of the following enzyme deficiencies in congenital adrenal hyperplasia can present with hypertension அப்படின்னு கேட்பாங்க. Hypertension அப்படின்னு கேட்கிறப்போ you have to select 11-beta hydroxylase. Okay. So next, 17-alpha hydroxylase is another commonly asked question. எங்க இருக்குன்னு பாருங்க. This helps in conversion of pregnenolone to 17-hydroxypregnenolone, progesterone to 17-hydroxyprogesterone. So அப்ப இந்த கார்டிசால் பாத்வே இந்த 17-alpha hydroxylase enzyme இருந்தா தான் வரும். So 17-alpha hydroxylase என்ன நடக்குது? கார்டிசால் இருக்காது. ஹைப்போகிளைசீமியா வரலாம். எஸ், ஹைப்போகிளைசீமியா வரலாம். Sometimes shock அவ்வளவு வராது because mineralocorticoid part will compensate for it, but still then can present. ஆனா என்ன நடக்கும்? மேஜர் ஃபைண்டிங் என்னவா இருக்கும்? இங்க கார்டிசால் பாத்வே கிடையாது. So 17-alpha hydroxylase இல்லைன்னா எல்லாமே கீழே சேனலைஸ் ஆக ஆரம்பிச்சிடும். எல்லாமே aldosterone production increase ஆக ஆரம்பிச்சிடும் இந்த இடத்துல. Since the aldosterone production gets increased, salt and water retention, hypertension. So CAH two enzyme deficiencies presenting as hypertension. என்னென்ன 11 beta hydroxylase and 17 alpha hydroxylase. Now we'll come again here. So நம்மளோட question என்னவா இருந்துச்சு? 3 days old female presented with severe hypotensive shock, altered sensorium. Shock நாலே ஒரு altered sensorium. அது போக லேப்ல பாத்தீங்கன்னா he has got hypoglycemia, his sugars are low. hyponatremia இருக்கு, hyperkalemia இருக்கு. fluid corrections கொடுத்து electrolyte corrections பண்ணி ionotropes கொடுத்தும் shock correct ஆகல. பாப்பாக்கு ஒரு metabolic acidosis இருக்கு. That point is not added in this question. metabolic acidosis இருக்கு. genitals ambiguous genitalia, ஒரு female genitalia with a virilized female genitalia மாதிரி இருக்கு. என்ன இமீடியட்டா பண்ணுவீங்கன்னா நெக்ஸ்ட் இமீடியட் லைன் ஆஃப் மேனேஜ்மெண்ட் சைல்ட் ஸ்டெபிலைஸ் தான் பண்ணணும். airway breathing circulation always comes first. Okay, இந்த இடத்துல ionotropes போட்டு refractory shock இருக்கனால I'm going to start on stress dose steroids after collecting samples for cortisol and 17 hydroxyprogesterone. So maximum 21 alpha hydroxylase மாதிரி தான் தெரியுது. So 21 alpha hydroxylaseல என்ன deficiency இருக்கும்? See, 21 alpha hydroxylase பொறுத்த வரைக்கும் 17 hydroxyprogesterone levels will be increased. 21 alpha hydroxylase ரோல் இந்த ரெண்டு இடத்துல தான் இருக்கு. progesterone deoxycorticosterone கன்வெர்ட் பண்றது, 17 hydroxyprogesterone 11 deoxycortisol கன்வெர்ட் பண்றது. So இப்போ எனக்கு 21 alpha hydroxylase போயிடுச்சுன்னா அதுக்கு மேல இருக்க 17 hydroxyprogesterone levels will increase. அதனால தான் நான் 17 hydroxyprogesterone levels வந்து ஸ்கிரீன் பண்றேன். In case of CAH, that too especially 21 alpha hydroxylase deficiency. இன்னொன்னு என்ன என்சைம் என்ன பார்த்தோம்? 3 beta hydroxysteroid DNase என்சைமும் காமனா கேட்கலாம். அதுல எல்லா பாத்வேஸ்மே ஷட் டவுன் ஆயிடும். எல்லா மேனிஃபெஸ்டேஷன்ஸ்மே இருக்கும் காமனா இருக்க மாதிரி. தென் ரெண்டு என்சைம்ஸ் ஹைப்பர் டென்ஷனோட பிரசன்ட் ஆகிறது எதுன்னு பார்த்தோம்? 17 alpha hydroxylase, 11 beta hydroxylase. Put this chart in your notice board. Similarly, initially சொன்ன மாதிரி எல்லாத்தையுமே உங்க கண்ணுல படுற மாதிரி போட்டுக்கோங்க. அடிக்கடி go through that, அடிக்கடி rehearse, only then you can remember well in enzyme exam. So இப்போ எனக்கு 11 beta hydroxylase போயாச்சுன்னா என்ன சொன்னோம்? deoxycorticosterone தான் accumulate ஆகும். So deoxycorticosterone accumulate ஆக what will happen if deoxycorticosterone gets accumulated? That itself can perform the function of mineralocorticoids. So it will cause salt and water retention. Okay. So next, இப்போ இதே எனக்கு 17 alpha hydroxylase deficiency ல cortisol pathway will get affected. அப்போ what happens? எல்லாமே aldosterone mineralocorticoid pathway side போய் இந்த எண்ட்ல வந்து I'll be having increased aldosterone. So increased aldosterone, salt and water retention, that itself can cause hypertension. So ரெண்டு enzyme deficiency hypertension present ஆகுது. 17 alpha hydroxylase, 11 beta hydroxylase. Never forget all these facts. That too, this is the most common scenario which will be asked in your exams. So repeatedly rehearse it. Next immediate line of managementன்றனால இந்த question. இதுதான் answer. Start on stress dose steroids. Yes. So next question. ரொம்ப straight forward direct question. ரொம்ப repeated question for NEET PG Pediatrics, NEET SS Pediatrics எல்லாத்தையும் repeated கேட்கிற question. The child with galactosemia is found to suffer more commonly from sepsis due to particular organism. என்ன sepsis? E. coli sepsis. So galactosemia என்ன sepsis காமனா வரும்? E. coli sepsis. Remember that. So never confuse it. Salmonella எந்த இடத்துல காமனா பார்ப்போம்? Sickle cell anemia. Sickle cell anemia especially osteomyelitis can be more commonly due to salmonella. Never forget that term. Next, a 1-year-old male child was brought with wet cough, pedal edema, cheilosis, angular cheilitis, pedal edema, swelling of legs and wet cough. So X-ray la cardiomegaly இருக்கு. Symptoms பாத்தீங்கனாலும் wet cough and pedal edema இருக்கு. Everything suggests some cardiac involvement. பாப்பாக்கு cheilosis, angular cheilitis இருக்கு. What is the vitamin deficiency associated with this condition? Skin manifestations or cardiac manifestations. எந்த vitamin deficiency ல வரும் கேட்டா we think of beriberi, thiamine deficiency. We have two divisions, wet beriberi, dry beriberi. Wet beriberi na cardiac manifestations, dry beriberi na neurological manifestations. So beriberi is because of thiamine deficiency. Thiamine replace பண்ணோம்னாலே all these symptoms will get reversed. This is also a direct straightforward question. So next, a child presents with erythematous patches in the perioral region with mucosal ulcers and impaired wound healing. So that's a small mistake there. The most likely mineral deficiency associated with this condition எங்கெங்க இருக்கு? எல்லா பெரிய ஆரிஃபிஷியல் ஏரியாஸ்ல இருக்கு, as well as palms and soles இருக்கு. மவுத் சுத்தி இருக்கு, gluteal regionல anal region சுத்தி இருக்கு, anal opening சுத்தி இருக்கு. Then palms and solesலயும் ஒரு peeling of skin, mucosal ulcers இதெல்லாம் இருக்கு. What is it? Acrodermatitis enteropathica. Acro palms and solesல இருக்கு, dermatitis enteropathica. So பெரிய ஆரிஃபிஷியல் ஏரியாஸ்ல எல்லாம் இருக்கு. So என்ன நமக்கு காமனா தெரியும், அயனா, ஜிங்கா, கால்சியமா, காப்பரா, ஸ்ட்ரைட் ஃபார்வர்ட் கொஸ்டின். அது இந்த இமேஜ் கொடுத்து கேட்கலாம், இல்ல அந்த மாதிரி மேல நம்ம கொடுத்த மாதிரி வேர்டிங்ஸ் கொடுத்து கேட்கலாம். So எப்படி கேட்டாலும் it is because of zinc transporter pathology. Immediately you start zinc, the symptoms will start reversing. So this is acrodermatitis enteropathica. Next, an infant is brought by parents with complaint that urine turns black on standing. Which of the following metabolic disorders is likely? This is also a very direct question, repeatedly asked question. என்ன கேட்டிருக்காங்க? Urine turns black on standing. Okay. First option is phenylketonuria. Phenylketonuria பொறுத்த வரைக்கும் history எப்படி இருக்கும்? Mousy urine, ஒரு developmental delay. இப்ப right now retardation of developmental milestones. So இதெல்லாம் தான் வந்து phenylketonuria பொறுத்த வரைக்கும் questions. Next, homocystinuria பொறுத்த வரைக்கும் how it will be? Third option, homocystinuria. Homocystinuria பொறுத்த வரைக்கும் question will be like, so increased thrombotic complications மாதிரி கேட்கலாம், இல்ல inframedial dislocation of lens, marfanoid habitus, இந்த மாதிரி ஏதாவது கொடுத்து எந்த enzyme, எந்த metabolic disorderல வரும் கேட்கலாம். homocystinuria. MSUD, maple syrup urine disease பொறுத்த வரைக்கும் yes, urine will have a maple syrup urine order. எந்த amino acids, branched chain amino acids pathology சொல்லி கேட்கலாம். So இதெல்லாம் காமன் questions. இந்த டிசீசஸ்ல இந்த மாதிரி questions அட்ரஸ் பண்ணலாம். நம்ம question என்ன? urine turns black on standing. Very very direct. எந்த amino acid metabolic disorder is likely to be associated with this? Alkaptonuria. So alkaptonuria la whenever you put your urine, whenever you expose it to the air, what happens? It just turns black, color changes. It is alkaptonuria. Okay. இன்னொரு question, alkaptonuria ஓட காமனா கேக்குறது ochronosis. So that is vertebral bodies la deposition ஆறனால you will get a condition called ochronosis. So alkaptonuria la இது ரெண்டு தான் common questions. Phenylketonuria is because of deficiency of phenylalanine hydroxylase. Alkaptonuria, homogentisate oxidase. Homocystinuria, cystathionine beta synthase. Maple syrup urine disease, it is because of branched chain dehydrogenase or branch chain dehydrogenase. And enzyme we get maple syrup urine disease. Okay. Next, 1-year-old child presents with bone pain and inability to walk. Fundoscopic examination la cherry spot இருக்குன்னு கொடுத்திருக்கான். What is the most likely diagnosis? What is the most likely diagnosis here? Bone pain இருக்கு, inability to walk. 1 yearல there is inability to walk, there is obviously developmental delay. Fundoscopy cherry spot இருக்கு, ஆனா organomegaly எதுவும் இல்ல. கீழ கொடுத்திருக்க ஆப்ஷன்ஸ்ல என்ன ஃபிட் ஆகும்? Tay-Sachs, Niemann-Pick, Hurler, Gotcher. Niemann-Pick பொறுத்த வரைக்கும் you will have splenomegaly, no doubt. Sphingomyelinase deficiency. Then lysosomal storage disease. Hurler, it's a mucopolysaccharidosis. Mucopolysaccharidosis obviously will have organomegaly, hepatosplenomegaly. Gotchers, the major examination, clinical examination finding is hepatosplenomegaly. First option, Tay-Sachs. Tay-Sachs la mattum you will not have organomegaly. Tay-Sachs la comes under gangliosidosis. So in the GM1, GM2 gangliosidosis la pathina, especially Tay-Sachs, you will not have organomegaly. Sandoffs, exosaminidase deficiency da rendume, exosaminidase B deficiency Sandoffs la you will have splenomegaly. No organomegaly. Cherry spot in kuduthanala our answer would be Tay-Sachs. Next, cherry spot both in ophthalmology as well as in pediatric IEM. It is a very commonly asked question. Cause of cherry spot: central retinal artery occlusion, any trauma, Niemann-Pick, Tay-Sachs, Sandoff, least is Gotchers. So அவ்வளவு காமனா Gotchers சொல்ல மாட்டோம். Niemann-Pick, Tay-Sachs, Sandoff, central retinal artery occlusion தான் ரொம்ப காமனா சொல்லுவோம். So that too when you take cherry spot. ஏன் cherry spot தெரியணும்? Everywhere in the retina you will have deposition of that gangliosides. So now GM1 gangliosidosis thana, sphingolipidosis, gangliosidosis. So that material will get deposited everywhere. Macula is a transparent area. So mostly behind that you have choroid. In choroid you will have deposition as well as that red layer of choroid will be just visible through this transparent macula. That is why we get this cherry spot. Next, a 3 months old male baby has deafness, cataract, missionary murmur in the infraclavicular area. What is the likely diagnosis? Deafness irukku, cataract irukku, missionary murmur in left infraclavicular area. Nothing but PDA, patent ductus arteriosus. So deafness கொடுத்திருக்காங்க, cataract கொடுத்திருக்காங்க, PDA கொடுத்திருக்காங்க. இந்த triad எதுல வரும்? Congenital triad. See the options. You have congenital HSV, herpes simplex, congenital rubella, congenital CMV, congenital toxoplasmosis. Congenital rubella la we get this. Also you have to see congenital rubella la enna deafness irukum, cataract irukum, PDA irukum solliyachu cardiac finding la. So deafness பொறுத்த வரைக்கும் sensory neural hearing loss ரொம்ப காமனா இருக்கும். Similarly rubella பொறுத்த வரைக்கும் first trimester la if you get the infection, the mother gets the infection, the chance of child going in for congenital rubella syndrome is high likely. 16 weeks கிட்ட இது mother gets infected அப்படின்னா mostly it will be having only sensory neural hearing loss. Other major abnormalities like cataract, PD எல்லாம் அவ்வளவா இருக்காது. If the mother gets affected in the late trimesters, then the symptoms or manifestations of or the probability of child getting congenital rubella syndrome will decrease. So first trimester the risk of getting congenital rubella syndrome is high. Also ophthalmologic findings, fundus you'll be having salt and pepper fundus. Congenital CMV பொறுத்த வரைக்கும் cytomegalovirusல yes அதிலே ரொம்ப காமன் என்னன்னு பாத்தீங்கன்னா apart from microcephaly, then periventricular calcifications இருக்கலாம் brainல. அதெல்லாம் தாண்டி ரொம்ப காமனா வருது sensory neural hearing loss. ரொம்ப common cause of sensory neural hearing loss due to some infection, torch infection எல்லாம் especially பாத்தீங்கன்னா CMV. CMV அதே மாதிரி CMV பத்தி சில questions கேக்குறப்ப how will you just test for CMV or confirm CMV? நான் டார்ச் பேனல் அனுப்புறேன், சிராலஜி அனுப்புறேன், IgM மட்டும் போதும், IgM CMV பாசிட்டிவ்னா I can confirm and I cannot confirm with that. I have to send urine CMV PCR test. Cytomegalovirus or a genetic material and the PCR பார்த்தாதான் I'll be able to find out urine CMV PCR. So PCR பண்ணா மட்டும்தான் I'll be able to identify or confirm CMV. The CMV congenital na CMV இருக்குன்னு confirm பண்றாங்க, what I going to do? I can just treat it with valganciclovir. So valganciclovir கொடுத்தேன் அப்படின்னா இந்த sensory neural hearing loss வரதெல்லாம் I can reduce, especially in UGR preterm children, if at all you are thinking for CMV infection. Okay, next. A 3-week-old infant complains of cough and sore throat. Mother reports that infant has paroxysms of cough followed by apnea. Total leukocyte count is more than 50,000 cells per microliter. What is the preferred drug for the above condition? Option 1, azithromycin. Option 2, amoxicillin. Option 3, cotrimoxazole. Option 4, clarithromycin. So, what is going to be my answer? Azithrova, amoxa, cotrimoxazole, clarithrova. What am I going to do? I have to find out what this condition is. என்ன சொல்றான்? Cough இருந்திருக்கு ஒரு 3 weeks child. Sore throat. Sore throat எப்படி 3 weeks old infant இருக்குன்னு சொல்றாங்க அப்படின்னு கேட்டீங்கன்னா that you cannot mostly tell, but என்ன எப்படி இருக்குன்னு பாத்தீங்கன்னா there will be excessive drooling of saliva. Whenever you think of pharyngitis or sore throat in infants especially, you will be having excessive drooling which you don't see normally otherwise. Normally there is minimal drooling, but the mother will say in the 1 to 2 days excessive drooling இருக்கு, excessive there is a drooling of saliva ன்னு சொல்லுவாங்க. So then the mother reports that infant has paroxysms of cough followed by apnea. So paroxysms of cough followed by apnea அப்படின்னு சொல்றோம். What is that? Nothing but whooping. Cough நிறைய paroxysms, bout of cough followed by apnea. Total leukocyte count elevated இருக்கு. என்ன கண்டிஷன் பத்தி டீல் பண்றோம்? Pertussis. So newborn periodல always remember that unexplained apnea இருக்குன்னா yes நம்ம வந்து நிறைய conditions apnea causes இருக்கு, apnea causes, but cough ஓட apnea இருக்குன்னா we normally think of pertussis. Apart from that, sometimes without cough it can also present just as a plain apneic spell. ரொம்ப plain apneic spell மாதிரியே present ஆகும். நார்மல் பிரசன்டேஷன், காமன் பிரசன்டேஷன் என்ன, பவுட்டா அப்படியே காஃப் பண்ணும் சைல்டு, சடனா அப்படியே அப்னிக் ஆகி ஒரு ப்ளூ கலர்ல அப்படியே சேஞ்ச் ஆயிடும், சைனோஸ் ஆன மாதிரி. திஸ் இஸ் தி காமன் பிரசன்டேஷன். டோட்டல் கவுண்ட்ஸ் will be elevated. How we are going to treat? We are just going to give azithromycin, this macrolide group of antibiotics. Actually the drug preferably to be used is erythromycin, but in newborn period it may cause infantile hypertrophic pyloric stenosis, so we prefer azithromycin. So this is a question dealing with pertussis. This is very commonly asked for pertussis. Next, so pertussis diagnostic criteria C. So who says the case diagnosed as pertussis by a physician, that itself. So the first criteria is nothing but any physician who diagnoses pertussis by clinical findings. The case diagnosed as pertussis by physician or a person with cough illness lasting at least 2 weeks with one or more of the following: paroxysms of cough, inspiratory whooping, post-tussive vomiting. Paroxysms of cough, inspiratory whooping, post-tussive vomiting. This is applicable for older children as well as adults. Whereas in newborn age group, it is just paroxysms of cough followed by an apnea or just a plain apneic spell. So இப்படிதான் present ஆகும் pertussis. This is a straightforward question. So vaccines commonly we get too much questions. In a 10-year-old child, which of the following vaccine is given as a part of school immunization program? So so whether it is measles, rota, TT or TD or HPV, nothing but TT or TD. So the answer is TT or TD. So tetanus toxoid தான் நம்ம கொடுக்கிறோம். TD here, sorry, it is not small t and d, it is capital T with small d. This is small spelling mistake. ஏன் அந்த மாதிரி கொடுத்திருக்கோம்னா The small capital T with small d na nothing but and diphtheria toxoid dose will be decreased. Diphtheria toxoid dose வந்து 2 Loeffler units தான் இருக்கும், அது decrease ஆயிருக்கும். So 10-year-old childக்கு நம்ம ஸ்கூல்ல கொடுக்குற immunization என்ன? TT. That's it. Next, which of the following vaccine is mostly associated with staphylococcal toxic shock syndrome, a serious adverse effect because of inadvertent dilution or breakage of cold chain? அப்படின்ற மாதிரி வந்துச்சுன்னா இங்கேயுமே vaccines there is small mistake, I'm sorry. So actually it should be capital M and capital R. It is measles and rubella vaccine. Predominantly MR vaccine la we get staphylococcal toxic shock syndrome, a serious adverse effect. Okay. Next, a child presents with intermittent jaundice and splenomegaly. So investigation revealed direct hyperbilirubinemia with gallstones. There's a family history of similar illness. Which of the following parameters in CBC will be useful to diagnose? So in the history வச்சே எல்லாரும் ஒரு finding வந்திருப்பீங்க. Image பார்த்தா you will be very well able to identify. இங்க என்ன இருக்கு? Apart from normal RBCs, normal RBCs தான் எப்படி இருக்கணும்? நம்ம biconcave shape அதெல்லாம் different. Biconcave எல்லாம் விட்டுருங்க. Apart from that ஒரு smearல இருக்கப்ப எப்படி இருக்கும் normal RBC? You'll be having a central paler. Central paler இருக்கும்னு சொல்லுவோம். இங்க பாத்தீங்கன்னா ஒரு சில RBCs எல்லாம் central paler இருக்கு. But இந்த RBCs எல்லாம் பாத்தீங்கன்னா there is no central paler. See, in all these RBCs you don't have any central paler. In the group of RBCs பாருங்க, you don't have any central paler. So in this group of RBCs, this one. Okay. So இங்க எனக்கு அப்ப என்ன பாக்குறேன்னா அந்த சென்ட்ரல் பேலர் இல்லாம இருக்க செல்ஸ் ஆர் நத்திங் பட் சென்ட்ரல் பேலர் இல்லாம இருக்க செல்ஸ் என்ன? They are nothing but ஸ்பியரோசைட்ஸ். So all these are ஸ்பியரோசைட்ஸ். So ஸ்பியரோசைட்ஸ் பொறுத்த வரைக்கும் எனக்கு ஹெரிட்ரி ஸ்பியரோசைட்டோசிஸ்ல மட்டும்தான் ஸ்பியரோசைட்ஸ் வரணும்னு அவசியம் இல்லை. எனி ஹீமோலைசிஸ் இன் itself will produce ஸ்பியரோசைட்ஸ். So இப்போ உங்க கொடுத்திருக்க பேராமீட்டர் சிபிசில எந்த பேராமீட்டர் will be useful to diagnose? அந்த இன்வெஸ்டிகேஷன் நெக்ஸ்ட் லைன் ஆஃப் இன்வெஸ்டிகேஷன் எல்லாம் கேட்கல. Next line of investigation for testing கேட்டா I know you all will tell osmotic fragility test. Now they are not asking that. They are asking which will be helpful here. So hereditary spherocytosis பொறுத்த வரைக்கும் you have to check some points. So hereditary spherocytosis, for autosomal dominant disorder, spectrin, ankyrin, band3 protein defects. So அதனால it's an RBC membranopathy, RBC membrane defect. So on the vertical and horizontal cellular integrity in the RBC membrane, vertical and horizontal integrity in the RBC membrane will get lost. So it is an RBC membranopathy. So hereditary spherocytosis எப்படிலாம் present ஆகலாம்? Can present as day 1 jaundice in newborn, can present as gallstones in later age group. So can present as day 1 jaundice, can present as gallstones, can present as direct, can present with direct hyperbilirubinemia as well. If there's gallstones obstruction, it can also present as direct hyperbilirubinemia. Indirect hyperbilirubinemia is common, but can also present as whenever there is obstruction due to gallstones. So pediatric case group la gallstones irukkunale, we always have hereditary spherocytosis in the corner of our mind. So hereditary spherocytosis screening la we use osmotic fragility test, confirmatory la use ectocytometry. Okay. So this is all about hereditary spherocytosis. Spherocytes you don't only see in hereditary spherocytosis, you also see spherocytes in any hemolysis. Sometimes even in dehydration you may have spherocytes. So இப்போ நமக்கு கேட்டிருந்த question வந்து which of the following parameters in CBC will be useful to diagnose? Always remember the only one anemia due to this hereditary spherocytosis that can be easily identified by this. It is because of this MCHC value. So MCHC, what will happen? MCHC will be elevated in spherocytosis. So MCHC will be very well elevated in spherocytosis. Mean corpuscular hemoglobin concentration. You know, the surface area is getting reduced. In spherocytes, the surface area is getting reduced, but the concentration, hemoglobin concentration remains static. So what happens? The mean corpuscular hemoglobin concentration will get elevated even though there is a hemolysis, What will happen? In hereditary spherocytosis, you get spherocytes, lack of central pallor, surface area gets reduced. But for that cell, for that decrease in surface area, the hemoglobin concentration remains static only within that RBC. So since it remains static, you see, the size also gets smaller. You get increased mean corpuscular hemoglobin concentration. With red cell distribution width, you cannot identify anything in terms of hereditary spherocytosis. IPF is nothing but immature platelet fraction. That is also not helpful in hereditary spherocytosis. PCV, packed cell volume, hematocrit. That will also not help in hereditary spherocytosis. Next, a child is brought to OPD with respiratory distress and biphasic stridor. X-ray is shown below. What is the diagnosis? What are you able to see here? This is nothing but steeple sign. So steeple sign. The history is, you check the options. You have acute epiglottitis, ALTB, acute laryngotracheobronchitis, foreign body, laryngomalacia. Where do we get steeple sign? We get it in ALTB. We get steeple sign in ALTB. So steeple sign. Will the child present? In case of laryngotracheobronchitis, it's or CRU. That too more commonly caused by the para-influenza group of viruses. So you see, whenever I think of CRU, the acute laryngotracheobronchitis, one thing that comes to my mind when we think of clinical scenarios, the child would have been very well. It wouldn't have much symptoms. Suddenly, it would present with low-grade fever with cough, and the cough would increase, and you'll be able to hear this noisy breathing, the stridor. So stridor here, the airway is nothing but a stable obstructed airway. Whenever you have stridor, yes, the airway is an obstructed airway. So you have a stable obstructed airway. So what is the main treatment in ALTB? CRU, humidified air oxygen. Then I have to give steroids, dexamethasone, along with adrenaline nebulizations. We give raw, undiluted adrenaline nebulizations, 0.25 to 0.5 ml per kg, maximum of 5 ml. If you just give a steroid to reduce the airway edema, as well as you give an adrenaline nebulization, you'll be able to very well see that the cough gets reduced. What is that cough? Barking cough. It will be a barking cough. Similarly, we saw whooping cough in pertussis. Here we get barking cough. In X-ray, you see there will be a narrowing in the supraglottic region. So that is why I get steeple sign. The similar history they have given. The child has fever, it is toxic looking, with drooling of saliva, respiratory distress, stridor. So respiratory distress, stridor, toxic looking, drooling of saliva, and X-ray shows thumb sign. You get thumb sign because of swelling near epiglottis. What is this? Nothing but acute epiglottitis, more commonly due to Haemophilus influenza. This you have to be very careful. You should not manipulate the child's mouth. You should not use any tongue depressors to visualize. You can see a cherry red epiglottis, a swollen epiglottis. If you keep manipulating, the child's airway can get obstructed at any time, and the child can go in for respiratory arrest. So always have an ENT backup whenever you are dealing with acute epiglottitis. So acute epiglottitis, the child will be toxic looking, sick looking, stridor, drooling of saliva. Whereas in ALTB, it will be barking cough, active child with a stable obstructed airway, having a barking cough with stridor. So here you will get steeple sign on X-ray. Here you will get thumb sign on X-ray. Repeatedly asked questions with such images. This you should not miss. Everyone can get full marks here. Next, a 2-year-old male child presented with hypoglycemia, and the child is a floppy baby. It has got hypotonia and hepatomegaly with elevated lactate. Almost everything is given. It is a very, very straightforward question. Most likely diagnosis, you have 3 options: Pompey's, Van Gierke's, Epstein, none of the above. You see Epstein's anomaly is obviously none of the above. It is not possible. You see Epstein's anomaly is a cardiac disease. Either the option should be between Pompey's and Von Gierke's. So when you see, you think Von Gierke's, it is because of glucose 6-phosphatase deficiency. That is also glycogen storage disease. Pompey is also glycogen storage disease. So the option here is lactic acidosis with hypotonia with hepatomegaly. When we think of Pompey's, Pompey's is mainly because of, we have to add certain points here. So whenever we discuss with about Pompey's, it is glycogen storage disease type 2. It is a lysosomal storage disease. Only lysosomal storage disease in the glycogen storage disease group. Due to acid maltase or alpha glucosidase deficiency. Alpha glucosidase or acid maltase deficiency is Pompey's. You will have increased lactate. Clinically, you will have hypotonia. Then it will just resemble a floppy baby. All glycogen storage diseases will be presenting as hypoglycemia, fasting hypoglycemia. So they may have hypoglycemia. They may have cardiac involvement, cardiomegaly, common. ECG may show, WPW syndrome. All these are features of Pompey's disease. Yes, now we have enzyme replacement therapy for Pompey's diseases. Well, this is also treatable. So all this you should know and remember about Pompey's. Next, a 2-week-old baby presented with vomiting, acidosis, cataract, immediately following. Also, the child, the question here is incomplete. I'll just add up certain points here. A 2-week-old baby presented with vomiting, acidosis, cataract. Also, you see the child worsened after starting breastfeeds on day 3. So the child was started on breastfeeds on day 3 of life due to some issues. Immediately after starting breastfeeds, within 2 to 3 days, the child started worsening. So the child had vomiting, diarrhea, intolerance of feeds as well. Now it has vomiting, metabolic acidosis, cataract with jaundice. What will you think of? Galactosemia. Already we saw a question with galactosemia. So what we saw? E. coli sepsis. The most common organism causing sepsis in galactosemia is E. coli sepsis. So galactosemia, there are many pathways. There are many enzymes that can be found with galactosemia and many enzyme deficiencies. So the classical galactosemia, the classic defect is mainly because of galactose 1-phosphate uridyl transferase. The other enzymes, galactokinase, yes, but it is to a lesser extent. Hexokinase and aldose reductase doesn't come here. The history is correlating with galactosemia, and the enzyme is galactose 1-phosphate uridyl transferase. Okay. Next question. A child with rickets has recurrent tooth abscess with normal calcium, low phosphorus, with high ALP, and recurrent tooth abscess with normal parathormone. Most likely diagnosis. So all this is repeatedly asked question. So இங்க பாத்தீங்கன்னா எனக்கு ரிக்கெட்ஸ் அப்படின்னு சொல்றப்ப ரிக்கெட்ஸ் ஒரு விஷயம் வச்சுக்கோங்க. இந்த கொஸ்டின் இந்த ஸ்லைட்ல இருந்து நீங்க கெயின் பண்ற ஒரு பாயிண்ட் ரிக்கெட்ஸ்னா இனிமே வந்து கால்சியம் பெத்தாலஜி நினைக்காதீங்க. ரிக்கெட்ஸ் ஒரு பாஸ்பேட் பெத்தாலஜி. So எல்லா ரிக்கெட்ஸ்லயும் லோ பாஸ்பேட் தான் இருக்கும். except in one etiology. Rickets due to a particular etiology will have high phosphate. So அது எதுன்றதை இன்னொரு கொஸ்டின் இருக்கு, பின்னாடி பார்ப்போம். So here இங்க பொறுத்த வரைக்கும் they are asking recurrent tooth abscess. அந்த பாயிண்ட் தான் clinching clinical feature. With normal calcium, low phosphorus, with high ALP, recurrent tooth abscess with normal parathormone. என்ன யோசிப்பீங்க அப்படின்னு கேட்டா nothing but hypophosphatemic rickets. நிறைய hypophosphatemic ricketsல நமக்கு X-linked dominant வேற. So இப்ப பாத்தீங்கன்னா the recurrent tooth abscess தான் major point. So the answer is hypophosphatemic rickets. Okay. Next. Which of the following cannot be seen in type 1 GSD? Type 1 GSD என்ன? It is nothing but Von Gierke's disease. Type 1 GSD is Von Gierke's disease. It is because it's a glycogen storage disease. Glucose 6-phosphatase deficiency. அப்ப என்ன ஆகும்? எனக்கு glucose 6-phosphateல இருந்து இந்த 6-phosphatase வச்சாதான் இதை கிளீவ் பண்ணி நான் குளுக்கோஸ் எடுக்க முடியும். அப்ப என்ன ஆகும்? இந்த பார்ட் வராது. So obviously hypoglycemia இருக்கும். ஏன்னா I cannot get glucose. மெயினா liver தான் involve பண்ணும். liver involvement தான் ஜாஸ்தியா இருக்கும். Apart from that, also I will have organomegaly. Splenomegaly can be seen, lesser extent. Hepatomegaly mainly. Renal enlargement. Don't forget this point. In von Gierke's, I will have renal enlargement. Apart from that, the child will have a doll-like facies in von Gierke's disease. What will happen now? This glucose 6-phosphate will go to pentose phosphate pathway. Pentose phosphate pathway. அப்படியே அங்க இருந்து அது பியூரின் pyrimidine synthesis எல்லாம் போய் at the end அங்க இருந்து uric acid levels rise ஆகி I get hyperuricemia. Similarly, glucose 6-phosphate மூலமா it can also lactate production could start going in. Okay, so even I can get lactic acidosis in von Gierke's disease. So glucose 6-phosphatase deficiency. See our question. You will have hyperuricemia, hyperlipidemia, lactic acidosis, hyperglycemia. In the option, which of the following cannot be seen? It is hyperglycemia. Always I have hypoglycemia. Okay, I have hypoglycemia. Next, which of the following is a lysosomal storage disorder? So my question here is lysosomal storage disorder. கீழ இருக்க 4 ஆப்ஷன் பாருங்க. Pompey's, von Gierke's, Corey's, Anderson. இந்த 4 question 4 ஆப்ஷன்ஸ்மே பாத்தீங்கன்னா nothing but glycogen storage disease. இதுல எது lysosomal storage disease னு கேக்குறாங்க. I'm already just now we discussed all these are repeatedly asked questions. Which of the following is a lysosomal storage disorder? Pompey's. So yeah, so the only LSD in the glycogen storage disorder group is Pompey's. So von Gierke, glucose 6-phosphatase. Corey's, it is branching enzyme pathology. Anderson, debranching enzyme. Corey's, it is Corey's, it is debranching enzyme pathology. Anderson, it is branching enzyme pathology. A, B, C, D. Anderson, A, Anderson, debranching. C, Corey, it is debranching. All this mainly involves liver branching and debranching enzyme. You will have hepatomegaly, you will have transaminitis as well. Okay. I have clubbed up all metabolism and storage disorder questions together so that it will be easy for you. A 6-year-old male child has burgundy red colored urine after playing for 1 hour. Initially he plays, then stops for 15 minutes and again plays because of muscle cramps. What is enzyme defect? விளையாண்டுட்டு நிப்பாட்டிட்டு திருப்பி விளையாடுறான். Nothing but second wind phenomenon. அதே மாதிரி ஒரு மயோக்ளோபினுரியா மாதிரி ஒரு burgundy red colored urine வருதுன்னு சொல்றான். What we are seeing here is glucose 6-phosphatase எதுல வரும்? von Gierke's disease. அதுல இந்த பிக்சர் வருமா? வராது. Last 3 and 4th option branching enzyme, debranching enzyme. அது ரெண்டும் liver தான் மெயினா இன்வால்வ் ஆகும். branching, debranching enzymes. அதுலயே பெருசா வராது. muscle இன்வால்வ் ஆறது ஆப்ஷன்ல இருக்குது muscle glycogen phosphorylase. What is it? McArdle disease. McArdle disease. Muscle glycogen phosphorylase or myophosphorylase deficiency. Here what happens? I have second wind phenomenon because of accumulation of those glycogen in the muscle. So this is also a glycogen storage disease. Type 5. Similarly, இன்னொரு muscle storage disease. Already muscles நம்ம நிறைய பார்த்தோம். 1 Pompey's, 2, then 5, then 7. இதெல்லாம் muscle GSDs. 7 is nothing but Tarwis. Muscle phosphofructokinase. அதுவும் ஒரு muscle disease தான். So இதுல அதே மாதிரி இன்னொரு பாயிண்ட் வந்து மயோக்ளோபினுரியா மாதிரி ஒரு பிக்சர் வித் பர்கண்டி ரெட் கலர் யூரின் வரும். அதே மாதிரி McArdle's disease பத்தி கேட்கறப்ப never forget second wind phenomenon. All these are very, 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 very commonly asked questions. Next, very interesting question. A 7-year-old boy, repeatedly asked question, has hyperpigmentation all over the body, and now he has presented with seizures. Now he has disturbance of vision for the past 1 month. His MRI is as below. What is the diagnosis? MRI la posterior predominant right occipital areas la involvement அதிகமா இருக்கு. Posterior predominant white matter involvement ஒரு white matter disease picture மாதிரி இருக்கு. First Krabbe's, Alexander, Canavan, X-linked ALD. The posterior predominant நாலே it is X-linked ALD தான். Krabbe's la கூட you can have tigroid appearance like picture, but the posterior predominant அப்படினாலே it is X-linked adrenoleukodystrophy. இதோட ஹிஸ்டரி எப்படி இருக்கும் அப்படின்னு பாத்தீங்கன்னா ஒரு டெவலப்மெண்டல் ரிக்ரெஷன் ஹிஸ்டரி மாதிரி தான் கேட்பாங்க. டெவலப்மெண்டல் regression. So that to X-linked male child, that to adrenal involvement. You see, you have hyperpigmentation, sometimes you have hypoglycemia as well. You'll have seizures, then will be developmental regression. At least step by step vision loss, then bone marrow involvement. So here you can do BMT for X-linked ALD. Also treatment will use a particular substance called Lorenzo's oil. Glyceryl triolate and glyceryl triuracate mixture. So Lorenzo's oil is used in the treatment of X-linked adrenoleukodystrophy. So this is a neuroregression disorder, neuroregressive disorders. That MRI which I showed before, never forget, that's a commonly asked question. Okay, next. Which of the following causes inherited conjugated hyperbilirubinemia? So I wish I have to tell you something like inherited conjugated hyperbilirubinemia. அப்ப எதெல்லாம் inherited unconjugated, inherited conjugated ஞாபகம் இருக்கணும். ஆப்ஷன்ஸ் பாருங்க, டுபின் ஜான்சன், second Crigler-Najjar, third Gilbert, fourth none of the above. So one thing I have to remember here is Dubin Johnson and Rotar belongs to conjugated hyperbilirubinemia groups. Crigler-Najjar and Gilbert belongs to unconjugated hyperbilirubinemia. Crigler-Najjar especially is due to UDP glucuronide transferase, UGT1A1 deficiency. Crigler-Najjar. So Crigler-Najjar and Gilbert are unconjugated. Conjugated hyperbilirubinemia is Dubin Johnson and Rotar. So another question that can be asked in Dubin Johnson is you have a pigment deposits in the liver. So pigment deposition in the liver can be seen in Dubin Johnson. Okay. So in Dubin Johnson, you can see pigment deposition in liver. Next, where is the foreign body located? There's nothing but this is an image-based question, repeatedly asked. Always remember that esophagus or trachea. Always remember the cross section. So esophagus, my vocal cords will be in this way. See this here. So for esophagus, the vocal cords. So vocal cords vocal cords. So my vocal cords will be in this way. So when the child swallows a coin and it enters into the trachea, so the vocal cords will be in this way. So say for example, coin இப்படி இருக்குனா coin இப்படி தான் இருக்கும். So coin இப்படி இருக்கும். So the coin ஓட slit இப்படி இருக்கும். So this is like this. This is like this. So my coin will be within this gap. So coin ஓட side தான் எனக்கு frontல visualize ஆகும். இப்போ PA வியூஓ AP வியூஓ எடுக்கிறேன்னா காயின் இந்த ஸ்லிட் மாதிரி தான் இருக்கும். ஏன்னா ஸ்பேஸ் இப்படி இருக்கு, காயின் இப்படி விழுந்திருக்கு, அதோட லேட்டரல் பார்ட் மட்டும் தான் எனக்கு தெரியும். ஸோ இங்க எப்படி இருக்கு, அந்த ஸ்லிட் மாதிரி தான் காயின் விஷுவலைஸ் ஆகுது. ஸோ யூ சி வாட் இஸ் திஸ்? This where is the foreign body? Trachea. இதே if it is in esophagus, what will happen? My coin will be esophagus straight, ஒரு horizontal slit tube மாதிரி இப்படியே இருக்கும். esophagus இப்படி இருக்கு. அப்ப காயின் விழுகுது அப்படின்னா காயின் will be like this. So coin will be like this. அதோட பார்ட் எனக்கு ஃப்ரண்ட் நல்லா தெரியும். So APO PO எடுத்தேன்னா ஸ்ட்ரைட்டா தெரியும் in case of esophagus. whereas in trachea slit மாதிரி தெரியும். இதே இந்த APPA வியூ இல்லாம லேட்டரல் வியூ எடுக்கிறேன்னா ட்ரக்கியாவோட காயின் டைரக்டா தெரியும். ஏன்னா லேட்டரல்ல இருந்து பாக்குறப்போ, லேட்டரல் ஆஸ்பெக்ட்ல இருந்து பாக்குறப்போ ட்ரக்கியாவோட காயின் டைரக்டா தெரியும். ட்ரக்கியால இருந்து காயின் டைரக்டா விஷுவலைஸ் ஆன மாதிரி இருக்கும் எக்ஸ்ரே. So here the answer is trachea. Next, in which cyanotic heart disease below finding can be seen? What is the finding here? Nothing but என்னது? Figure of 8 appearance. So figure of 8 appearance I get in TAPVC. So see, certain heart diseases have certain X-ray findings like TOF. You all know boot-shaped heart, Poyer in Sabot, TGA, egg on string appearance. Egg on string appearance. Epstein anomaly. In Epstein's, you have a very huge heart, box-shaped heart. TAPVC, I get snowman or figure of 8 appearance. இதே மாதிரி இதெல்லாம் கேட்கிறப்ப which cyanotic heart disease is exclusively associated with left axis deviation on X-ray ன்னு கேட்பாங்க. left axis deviation on X-ray. நம்ம எதை சொல்லுவோம்? tricuspid atresia. இதுதான் ஆன்சர். cyanotic heart disease இதுவும் காமனா கேட்கிற question. So tricuspid atresia associated with left axis deviation. Okay. So நிறைய appearances பார்த்திருக்கோம். அதை ஞாபகம் வச்சுக்கோங்க. எப்ஸ்டீன் அனோமாலி மேனிஃபெஸ்டேஷன்ஸ் பொறுத்த வரைக்கும் எப்ஸ்டீன் அனோமாலி எப்படி பிரசன்ட் ஆகலாம் அப்படின்னு கேட்டாங்கன்னா Epstein's anomaly maybe first decade pick up, second decade pick up. So it will be presenting as a very huge heart. As well, you'll be able to hear multiple clicks Epstein's anomaly. So the downward displacement of tricuspid ring aperture and atrialization of ventricle is mainly the pathology in Epstein's anomaly. Okay. So all this is about cyanotic heart disease. Also, partial anomalous pulmonary venous connection, you call something as Smith-Tart sign on X-ray. This also you should know for exams. Very important. Okay. Next. Which of the following deficiency causes hypertension? Already we have seen two enzymes. And the enzymes or no? 11 beta hydroxylase, 17 alpha hydroxylase. So in the enzymes mattumna hypertension cause pannakudiyadhu. Namakku idhula option la irukkiradhu 11 beta hydroxylase. Next. Which of the following is the best treatment for the clinical scenario given below? So first you have to analyze what is the scenario. A 5-year-old male child, 5 days fever, cervical lymphadenopathy more than 2 cm with conjunctival congestion and peeling of hands. என்ன syndrome கொடுத்திருக்காங்க? Kawasaki. Kawasakiல நார்மலா fever more than 5 days with அடுத்த கீழ இருக்க 5 criteriasல any 4க்கு மேல இருந்தா we take it significant. So அதுல skin பொறுத்த வரைக்கும் acute you can see swelling of hands and arms. Subacute பாத்தீங்கன்னா desquamation, peeling of skin. Then acute erythema இருக்கலாம் skinல. Then you may have a bilateral non-purulent conjunctival injection. Nothing but ஒரு sterile conjunctival discharge இருக்கும். Sterile conjunctival congestion. So conjunctival congestion இருக்கும் non-purulent. Then when it comes to cervical lymphadenopathy, any one side, if it is more than 1.5 centimeters, we take it significant. Apart from that, oral cavities. So oral cavities பொறுத்த வரைக்கும் எனக்கு என்னென்ன findings இருக்கும்? I may have pharyngeal congestion, I may have strawberry tongue, I may have cracked lips. இதுல என்ன இருந்தாலும் we take it significant. So இந்த criteriaல any 4க்கு மேல இருந்தா I diagnose that as Kawasaki disease. Kawasaki disease பொறுத்த வரைக்கும் why I am jumping in for Kawasaki? Because if untreated, it will lead to coronary aneurysms. So as fast as possible, I wish to treat Kawasaki. Kawasaki is a clinical diagnosis. Never forget that it is a clinical diagnosis. So what is the treatment for Kawasaki? IVIG is the treatment for Kawasaki. Dictum adha IVIG da kudukka poren. So 2 grams per kg over 24 to 48 hours I will complete in case of Kawasaki. So Kawasaki ki treatment adha. So once you give IVIG within 24 to 48 hours you will see a response. The fever will disappear absolutely. So in Kawasaki criteria I may have acute changes, skin changes, erythema irukkalam, then edema of hands, dorsum of hands irukkalam. Then subacute you may have desquamation of skin, peeling of skin, nail changes. Apart from that, you may have some maculopapular rash or any sort of rash. Remember, you will never have vesiculobullous rash in Kawasaki, especially you will not have vesicles in Kawasaki. Then you may have cervical lymphadenopathy. Then you may have conjunctival congestion, bilateral. That too, you see this conjunctival congestion is very, very transient. Sometimes it will just disappear in 24 to 36 hours and the parents may not give you this history. So when taking it as account in criteria, you may miss it. So ask them whether there was any conjunctival redness and it disappeared immediately. So maximum irundhuchu அப்படின்ற history அதுக்கப்புறம் கொடுப்பாங்க. Then oral பொறுத்த வரைக்கும் cheilitis இருக்கலாம், cracked lips இருக்கலாம், strawberry tongue இருக்கலாம், pharyngeal congestion இருக்கலாம். So second week of Kawasaki பொறுத்த வரைக்கும் Kawasakiல lab findings பார்த்தா you will have thrombocytosis. Second week of disease la when there is desquamation of skin associated with thrombocytosis. So Kawasaki, if you're not treating it, lead to coronary aneurysms. Kawasaki IVIG poturuven. At the same time, I'll start the child on aspirin till the fever resolves. It will be on high dose aspirin like 50 to 75 mg per kg per day. Then I'll decrease the dose of aspirin and I'll continue aspirin for 6 weeks. If the child has got the coronary aneurysms, dual antiplatelets, aspirin, clopidogrel will be continued. So you have to keep the child in follow for at least 1 to 2 years. So Kawasaki is a highly treatable condition. The main line of treatment is IVIG. Never forget it is IVIG. So here see they have given about IV vancomycin, wait and watch, IVIG, IV amikacin, it is IVIG. Vancomycin normally whenever you have a toxic shock syndrome, shock, you're thinking of staphylococcal toxic shock syndrome. If they are given a picture like that, you think of vancomycin. Next. erythema infectiosum, slapped cheek appearance, fifth disease. All this is nothing but associated with parvoviral infection. So next, 37. Which of the following is not necessary for intrauterine growth? A very, very repeatedly asked question. So first option is thyroid hormone, second option is cortisol, third option is IGF, fourth option is growth hormone. Normally what we'll do, we'll be very much tempted to tick IGF or cortisol, something like this. But normally remember that growth hormone is not necessary for intrauterine growth. Take home message from this slide is growth hormone intrauterine growth க்கு தேவையில்லை. அப்ப growth hormone deficiency ஓட இருக்க child normal birth length ஓட தான் பிறக்குமானா, yes, it will be born with normal birth length. Normal birth length எவ்வளவு சொல்லுவோம்? 50 cm சொல்லுவோம்னா அது normal growth hormone deficiency child normal birth length ஓட தான் பிறக்கும். Later then it will have faltering growth velocity, height velocity குறைய ஆரம்பிக்கும். So growth hormone not necessary for intrauterine growth. Remember that. Thyroid hormone, cortisol, insulin-like growth factors play a major role in intrauterine growth. Okay. Next, which of the following is the first response to the treatment of iron deficiency anemia? So iron deficiency anemia, how we treat? We treat with iron. We give dose at 3 to 6 mg per kg per day or 4 to 6 mg per kg per day. Normally we keep at 4 mg per kg per day nowadays. So iron is the treatment dose. So whenever I give iron within 24 to 48 hours, my first change will be increase in enzyme levels. So iron containing enzymes like cytochromes. So இதனால என்ன ஆகும்னா appetite increase ஆகி generalized well-being will increase. Iron containing enzymes increase ஆகுறனால இந்த change வரும். That will occur within 24 hours itself. So this is the first sign I get. அப்ப இந்த ஆப்ஷன் கொடுத்திருந்தாங்கன்னா first response to treatment ன்னு கொடுத்திருந்தாங்கன்னா this should be my answer. இதே first laboratory response அப்படிலாம் கொடுக்குறாங்க அப்படின்னா then the answers will change. First response அப்படி கொடுத்தாங்க clinical response தான் டிக் பண்ணலாம். Answer is this. Next பாருங்க, அதுக்கு அடுத்து வந்து 36 hours to 48 hours இவ்வளவு bone marrow erythroid hyperplasia. அப்புறம் 48 hours ஸ்டார்ட் ஆகி at fifth day நல்ல பீக் ஆகும். என்ன reticulocyte production will increase. Later after 1 week I'll have hemoglobin level increase, MCV starts increasing. Then at the end of 1 month later, ferritin will rise. At the end of 3 months, iron stores will completely increase. And iron stores increase பண்றதுக்காக தான் we suggest treatment minimum for 3 months in case of iron deficiency anemia. Next question, which of the following is associated with hyperphosphatemia? இந்த question நான் ஃபர்ஸ்டே சொல்லியிருந்தேன். ricketsனாலே நம்ம phosphate pathology உங்க மைண்ட்ல நிக்கணும். அதுவும் phosphateல predominantly rickets வந்து hypophosphatemia தான் இருக்கும். hyperphosphatemia இருக்கிற ஒரே ஒரு rickets கேட்டா என்ன ஆப்ஷன்ஸ் பாருங்க. Vitamin D dependent rickets type 2, hypophosphatemic rickets, vitamin D dependent rickets type 1, CKD. Nothing but CKD. CKD is the rickets. It's the type of, it's the etiology of rickets that is associated with hyperphosphatemia. Hyperphosphatemic rickets, CKD. Never forget. Next question. A 3-year-old boy with marfanoid status, with intellectual disability, with inferomedial dislocation of lens. What is the enzyme defect that is associated with it? I'm already the pathirkom. So nothing but homocystinuria. Homocystinuria என்ன enzyme defect இருக்கு? Homocystinuria enzyme defect என்ன? I'm sorry, cystathionine beta synthase. The question என்ன? So see here, a 3-year-old boy, marfanoid status, intellectual disability with inferomedial dislocation of lens. So நமக்கு lens dislocation பொறுத்த வரைக்கும் ரெண்டு தான், supero-temporal, inferomedial னு கொடுப்பாங்க. Marfan syndrome நார்மலா that will be a supero-temporal, whereas homocystinuria that will be inferomedial. அப்ப இதுல என்ன enzyme defect வருதுன்னு கேட்டா it is cystathionine beta synthase. Homocystinuria என்ன enzyme defect? Cystathionine beta synthase. Tyrosine transaminase எதுல வரும்? Tyrosinemia type 2 ocularல. Then phenylalanine hydroxylase, phenylketonuria. Homogentisate oxidase, alkaptonuria. So நமக்கு தேவை homocystinuria என்ன enzyme defect வரும்? Cystathionine beta synthase. Next, in which vitamin deficiency do we get the below sign? என்ன sign இருக்கு? Closely observe this. In the X-rayல you have a Wimberger ring sign. என்ன sign? இந்த இடத்தை நோட்டீஸ் பண்ணுங்க. Keenly notice this part. So if you notice this part, you have two ring-like things. There is nothing but Wimberger ring sign. So Wimberger ring sign, where do I get? Wimberger ring sign I get in scurvy. So around that my ossification center of epiphysis, I just have a bleeding. That produces a ring-like appearance, Wimberger ring sign. In case of scurvy due to vitamin C deficiency. Also, I'll be having subperiosteal hemorrhages. White line of Frankel. Telkamp spur. All these are radiological findings in scurvy. So, நமக்கு கொடுத்திருக்கிறது ஸ்கர்வியோட கொஸ்டின் தான். அதுல விம்பர்கர் ரிங் சைன், விம்பர்கர் சைன் இஸ் seen in syphilis, விம்பர்கர் ரிங் சைன் இஸ் seen in scurvy. So நமக்கு இது ஆப்ஷன் வைட்டமின் சி scurvy. விட்டமின் டி ல rickets. So then thiamine ல beriberi. Vitamin A deficiency manifestations are entirely different. So vitamin A deficiency we get nyctalopia, night blindness. The visual cycle, rhodopsin, iodopsin pigments எல்லாம் affect ஆகும். So நமக்கு இங்க கொடுத்திருக்கிறது விம்பர்கர் ரிங் சைன், வைட்டமின் சி, வைட்டமின் டி அண்ட் வைட்டமின் சி. வைட்டமின் டி வந்து especially mineralization defect. Osteoid formation le we have a defect na, it is because of vitamin C. Okay, so almost I think we have discussed some 40 important high yielding questions regarding IEM, development, bit questions from endocrinology, and then also we have seen some hematology questions, Kawasaki, certain cardiology questions, questions regarding hyperbilirubinemia has been discussed. So when we discussed about hyperbilirubinemia, I thought I'll add up some points here regarding physiologic and pathologic jaundice that will also be asked commonly. So pathologic jaundice, if someone asks you in newborn period, I'd like to add certain points. If jaundice appears on day 1 of life, it is pathologic jaundice. If it lasts more than 2 weeks of life, it is pathologic jaundice. Whenever in life you have direct hyperbilirubinemia, it is pathologic jaundice. At any point of time, if palms and soles look icteric in a newborn, it is always pathologic. All these has to be evaluated. You should never forget that. So almost we have discussed many IEM, many image-based questions, and also we have discussed questions about general normal newborn findings. So thank you for your patient listening. So if you want to just know more about this and you have to wish to subscribe to Synapse Sprint NEET PG, just WhatsApp to this number. Also, you can join in Telegram group using this QR code. We hope that the session was enlightening and it was fruitful to you. Thank you all. Thank you.